pleasant good evening to one and all gathered here. Distinguished faculties, API committee members, respected delegates, and my dear students. I am Dr. Mohammad Ramaz Murtuza, and I welcome you all on behalf of Trichy API to the 18th annual conference of API TAPICON 2022. We welcome you all to this knowledge tour on internal medicine, and we hope you all will have a great journey these 3 days, during which you will acquire critical knowledge which we can apply in our daily clinical practice. We will be starting our conference with the corporate symposium today, followed by a wide variety of topics covering internal medicine for the next 2 days. I now request our API chairman, Dr. Sethuraman sir, to please give a talk.
Good evening to all of you. It gives me immense pleasure to see you all in this auditorium today evening. The conference is beginning now, 3 days conference. Today is the corporate symposium. 5 topics, 5 lectures will be there, each for 20 to 30 minutes. After the lectures, there is a dinner in the hall below, Nivandam Hall. So I request all of you to be present till the dinner and enjoy the evening. And today is the corporate symposium is nurtured by our Dr. Shanmugavelu, who is the man behind this, arranging all this. Please give a good clap to him. So the topics and the speakers are well-learned people who is going to deliver. It will be very useful to you. Tomorrow, the session starts at 8:30 to 9 in the 2 halls. This is called Hall A. Another hall is there in Hall B, where the poster presentation is going on. So with these few words, I invite you, all of you, for this conference, and the beginning is the corporate symposium today. Thank you very much.
I now request Dr. Shanmugavelu sir, so to please give his talk. Thank you.
Mike, right. So very pleasant evening and a cordial welcome to everyone gathered here tonight. It's such a delight and privilege to be standing here and addressing you all at the 18th annual conference of API, especially happening in our rock city, Trichy. I'd like this wonderful opportunity to express my immense gratitude and appreciation to our most valued dignitaries, distinguished members, passionate delegates, beloved colleagues and friends far and near for being a part of this grand convention and gracing it with their presence. At this precious moment, I sincerely acknowledge each and every member for the diligent efforts that contributed to the success of this big event. It's true that the art of sharing knowledge and expertise among professionals builds a strong network that has a profound impact on the global medical community. On this special occasion, a series of brainstorming sessions are going to take place to enhance our skills and reinvent ourselves in day-to-day practices. I assure you all that this symposium will be a fruitful one in every aspect. Thank you for your kind patience in listening to me. Have a pleasant stay and a memorable time. Now to move ahead, I request our esteemed first company, yes, Novo Nordisk. May I call, yes.
The first speaker for the corporate symposium today evening will be Dr.
Sorry, no, first Novo Nordisk people, let them come, let them in.
So
and
I now request the Novo Nordisk marketing head to welcome the delegates.
Good evening, everyone. On behalf of Novo Nordisk, I am Dr. Shanmati, Regional Medical Advisor. I would like to thank TAPICON and all the organization and Dr. Shanmugavelu sir for providing us this opportunity to be a part of TAPICON. And with this, I would like to introduce Dr. Tyagarajan sir, Professor of Endocrinology Department from PSG Medical College, for giving a session on oral semaglutide. Sir is part of American Board Certified Obesity Medicine, and he has done he has been invited to compete in the Endocrinology Society's Presidential Poster Competition, and he is the House Officer of the Year, University of Nebraska Medical Center, and he is the Best Fellow Poster Award and University of Nebraska Department of Internal Medicine. And sir has multiple publications, and he's been a part of various trials and advisory boards. Now I would like to welcome Dr. Tyagarajan sir for the session.
So, introduction. So, respected senior doctors, guest speaker, Professor Dr. Tyagarajan, and members of the former company, I feel extremely happy, honored, and most privileged to have been invited to chair this particular session. I'm sure type 2 diabetes is a multi-causal, heterogeneous, progressive cardiometabolic condition, and the progressive nature is one of the major challenges. So, getting the patients to goal become challenging as the disease progresses. Multiple intervention will need to be used for managing diabetes. There was an article published May 2009 in JAPI. This particular article highlighted the importance that newly detected patient with the type 2 diabetes, they have very high levels of DPP-4 enzyme in the fasting state that gets amplified in the postprandial period. So there is a definite role for incretin-based therapies while managing our patient with the type 2 diabetes, number one. Second important thing is, we have incretin-based therapies which address 6 out of 8 ominous octet, which are the factors that contributing to overall hyperglycemia patient with the type 2 diabetes. That is number two. Third important thing is, under incretin-based therapy, we have DPP-4 inhibitors as well as GLP-1 receptor analogs. These GLP-1 receptor analogs, as of now, are available in an injectable formulation. This can be given twice daily or once daily or once weekly. So very important thing is, fear of injections may still remain a major barrier to use GLP-1 receptor analogs. If you look into the patient perspective, the patient would like to prefer to have a therapy which should be simple, number one. Number two, it should be non-invasive. And third important thing is, it should be convenient for them. So under this, several peptides, several attempts have been made to prepare this peptide in a oral formulation, but these methods have failed ultimately. Now Novo Nordisk, they have brought a new innovation, that is a peptide available in a oral formulation, that is semaglutide. So for this, may I request Dr. Tyagarajan to take all of us through his presentation. Over to you, sir.
Good evening, everybody. I'm Dr. Tyagarajan. I'm a consultant endocrinologist from Coimbatore. I thank the organizing committee of TAPICON for giving me this opportunity for discussing about the oral semaglutide preparation here. Slide. Oh. Slide move. Sorry for the delay. We'll be projecting the slides in a minute here. Okay, good evening again. Dr. Tyagarajan. We'll be discussing about the oral GLP-1 receptor agonist semaglutide on today's topic. The topic is pioneering the upstream approach in diabetes management with oral GLP-1. So we'll see what is upstream approach and what is downstream approach in a while. So this is my financial disclosure, but no conflict of interest in particular to this presentation. So today's outline would be, we'll be talking about the burden of weight or the burden of overweight and obesity in the type 2 diabetes. And then we'll address the sinister relationship between the obesity and diabetes and how we can combat this with an upstream approach. And where does the oral semaglutide take a place in the management of this? And then we'll have a short case study to discuss these points. So we'll just talk about the burden of metabesity or diabesity. 67% of people with type 2 diabetes in India have obesity. 1 in 10 patients or 1 in 10 adults in India have type 2 diabetes. This may be going up. We may be reaching up to 14%. 20% of the patients with type 2 diabetes are overweight, and up to 67% of them are obese. When you have obesity combined with diabetes, there's a 7 times increased risk of all-cause mortality. And we have discussed this in the past in several other conferences. We have the thin fat Indian phenotype, or the thrifty gene hypothesis, or the YY paradox. Even though South Asians, particularly Indians, have a lean body mass, we tend to have more subcutaneous as well as visceral fat, which makes us more prone for getting diabetes and also an early stage diabetes. So this is the sinister synergism we were talking about. We talk about how the adiposopathy or the dysfunctional adipose tissue and diabetes play a hand-in-hand role, and each one will worsen the other. So in the physical environment, because of the food or the lack of physical activity, maybe alcohol and so on, may lead to more worsening of diabetes, sleep disorders, inability to be active, and the stigma and impaired mental health because of the obesity may lead to even more disadvantages in the social environment, may also be because of income inequality. Whereas in the form of because of diabetes, many of the medications used to treat diabetes, including insulin and sulfonylureas, may cause weight gain. And because of the diabetes-induced peripheral neuropathy, the physical activity may be decreased. And because of again medication treatment, hypoglycemia may induce more stimulation of food intake, leading back to increased weight gain. So at the core of this, we have 2 problems: the insulin resistance and the beta cell decompensation. So what are some of the complications due to overweight or diabetes or obesity? We'll just focus on the cardiovascular complications, namely the cerebrovascular disease, the coronary artery disease, and the peripheral vascular disease. But we also have several other non-cardiac cardiovascular complications, including depression, hypertriglyceridemia, osteoarthritis, urinary incontinence, obstructive sleep apnea, GERD, and non-alcoholic fatty liver disease, which is not been adequately controlled at this point here. So this is the upstream and the downstream approach we are talking about. We'll have a case example at the end of the talk here. So, when we address the obesity or the adiposopathy upstream, we can prevent the cardiovascular and non-cardiovascular complications that may happen at the downstream, and may lead to hyperglycemia and lead to more micro and macrovascular complications. Instead of dealing with the complications later on, it's better to approach the adiposopathy early on in the disease process. So what's the importance of dealing with it upstream or at the beginning stage of the disease, where we still have quite a chance to stop the progression? So weight-centric approach in managing the obesity or the adiposopathy will lead to disruption of the underlying pathophysiology of the type 2 diabetes, which is the inflammation, leading to both insulin resistance as well as beta cell dysfunction. And then it is also possible to have a reversal or at least a slowdown of the underlying disease process. So at the same time, not just by addressing diabetes, but independently by itself, by addressing the obesity, we can also improve the cardiovascular risk factors and prevent micro and macrovascular complications. Now we'll move on to some of the key studies done in the past, where we have shown that a moderate or at least a moderate weight loss will lead to prevention from progression of type 2 diabetes. So this is the diabetes prevention program study as well as the docking study from China. So both of this has shown that the risk of type 2 diabetes will fall significantly when there's a reduction in the body weight. So even a 5 kilogram weight reduction will decrease the risk of progression to type 2 diabetes. And then as the more weight has been is lost, like up to 15 kilogram weight loss, you decrease the incident occurring of type 2 diabetes by even more higher percentages. Now this is the look ahead trial. Again, this was done in the United States also. It was more of a intensive lifestyle intervention study, where the caloric amount was restricted compared to standard of care. And you can see that even a modest weight loss, like between 5 and 10% of the body weight, will have a definitive decrease in the HbA1c by up to 0.5%. And more weight being lost, like say more than 15% of the body weight being lost, you get even more reduction in the HbA1c. So same with the fasting glucose as well. So even a smaller percentage of body weight loss, an optimum number would be somewhere between 5 to 10%. If you remember, even from the diabetes prevention program, even though the goal was set at 10% of body weight loss, most people lost only up to 7% of the body weight, and that itself has prevented from progressing to pre-diabetes to diabetes in those patients. So again, even a modest weight loss of about 5% will confer benefits to our patient in terms of reducing the progression to type 2 diabetes. Now moving on to the DIRECT trial, which is the more recent trial done in the UK, and this is from the durability study that was published after 2 years after the initial study was published. And you can see this is also an intensive lifestyle intervention study compared to standard of care. And you can see here, despite what approach was used, either the intensive therapy or the standard of care, the more weight the patient has lost, the more people remained in the type 2 diabetes remission, which was defined as HbA1c remaining less than 6.5% without any medications. So in this particular case, you can see that 46% of the people in the intervention group, again this is only intensive lifestyle, no medications, achieved type 2 diabetes remission. And greater the weight loss, the greater the chance of remission from type 2 diabetes. So you can see here again 5 to 10 kilograms, 10 to 15 kilograms, or more than 15 kilograms weight being lost. In the more than 15 kilogram light, at the end of 2-year period, 86% of the patients were able to keep off the or keep the diabetes under remission. So what are some of the interventions we can do for our patients with obesity or overweight to lose weight? At the core of all this is the lifestyle, diet and behavioral therapy. And that dietary therapy, any diet that the patient would be following will work. This could be a low carb diet, low fat diet, it could be a ketogenic diet, it could be a intermittent fasting, any diet, but a diet the patient sticks to will help him or her to lose weight. Next is physical activity, and the third is behavioral therapy, and then several patient support systems, constant engagement with the care team to help with them to stick to the lifestyle changes will help them lose weight. Next comes pharmacotherapy. Some of these medications are available in India, some of them are not. But these are some of the commonly used medications here, the Orlistat, and then we have the liraglutide, the higher dose up to 3 milligram dose. And then we have the injectable semaglutide up to 2.4 milligram dose, which again is not available currently in India, but is expected to be arriving soon. Then we also have the Contrave or the fixed dose combination of naltrexone and bupropion, again not available in India yet. And then the Qsymia or the phentermine topiramate combination. Next, we move on to the weight loss surgery. The first two are going out of fashion, I would say. But then the Roux-en-Y gastric bypass surgery and the sleeve gastrectomy are still very powerful approaches to lose weight, and may help our patients with type 2 diabetes keep it in remission. Other medications are in pipeline, and we will be learning about them in the future, but these are current options we have here. But what are some of the unmet needs in some of the weight loss therapies here? Whether the patient would be able to sustain the weight loss, what's the quality of weight loss? Many of our patients may be, have sarcopenic obesity, meaning they may be obese, but they may be losing their muscle mass. So we don't want our patients to lose weight, particularly lean mass, and retain their fat mass. So if we want them to lose weight, we want them to lose their fat mass. So that is the quality of weight loss we would want to expect. And then the effect of anti-diabetic drugs. Some of the medications we use concurrently for managing diabetes may actually be counterproductive in increasing their weight. So there is this one area that this is an unmet need here. We need something that would address all this particular gap here. And that's where the GLP-1 receptor agonists come into play. It has multiple benefits. First, it reduces the HbA1c, fasting, and postprandial glucose, especially the newer ones, the longer acting ones. And then we have a very minimal risk of hypoglycemia when they are used by themselves. Decrease the weight is reducing, and that is the more important factor in my opinion. The maximum benefit in the patient gets from a GLP-1 receptor agonist. And then the cardiovascular benefits, about the LEADER trial, the REWIND trial, and the SUSTAIN trial, where they all showed that the GLP-1s have offer significant cardiovascular benefits. And then the side effect profile, some of the patients do get GI side effects, but if carefully selected patients and careful expected management, we can minimize this GI side effects. And then they are approved for a wide variety of patients. We will talk about them in a little bit here. So this is the proposed primary and secondary brain activation pathways by semaglutide. Dr. Shanmugavelu sir mentioned earlier that the GLP-1 receptor agonist address at least 6 of the 8 the pathophysiological mechanisms underlying type 2 diabetes, and one of them is the brain transmitter things, and this is particularly in relation to obesity, whether to address the hunger, whether to address the satiety center, or in the hedonic forebrain, whether to address the interest in food. All this are addressed by the semaglutide or GLP-1 receptor agonist in general. It acts both on the hindbrain, it acts on the hypothalamic satiety centers, and also in the forebrain here through various pathways, either directly or indirectly. So this is a small study done using oral semaglutide. The number of patients were less, only like 13 or 14, and this is a crossover study. Patients were initially on oral semaglutide and then switched over to placebo, and then the other half are switched back to semaglutide. And particularly looked at what's the oral intake is, how much is the calorie intake, and also they did a body composition analysis. So we talked about the quality of weight loss, meaning whether fat mass is lost rather than lean mass, and you can see in the oral semaglutide group the body weight lost was about 2.7 kgs. This is about 12 to 24 week study, whereas in the placebo it's only like 1.1 kilogram weight loss. And then most of the weight lost is actually fat mass. So out of the 2.7 kilograms, 2.6 kilograms mean weight lost was actually fat mass loss. And if you look at the whole body lean mass, there's a very negligible lean mass that is lost during the study here. So now we move on to the set of clinical trials, the phase 3 clinical trials done using the oral semaglutide, the pioneer studies, and we will see that how oral semaglutide helped achieve our patients to reach their glycemic targets as well as their weight loss targets. The Pioneer 1 study, it is a study comparing placebo with oral semaglutide. The 7% of HbA1c loss was achieved by all three doses of this oral semaglutide, the 3, 7, and the 14. The 7 and 14 actually having a statistical significance. And in the weight loss, also more than 5% weight loss was lost by all three doses of the semaglutide compared to the placebo here. So 8 out of 10 people who were on semaglutide lost about came to the HbA1c less than 7%. And as far as the Pioneer 8 group, which is actually the study where the patients were already on insulin and oral semaglutide was added on top of them, here also you can see that weight loss more than 5% were achieved at week 26 by 41% of the study participants who were on the 14 milligram dose, and at the week 52, this was sustained, like more than 49% of the study subjects lost more than 5% of their body weight. So out of 1 in 2 patients who were on the semaglutide at all three doses were able to achieve the weight loss of more than 5%. About only a small number, 5-6% were on this 3% dose, and 1/3 of the patients were on the 7 milligram dose, and the rest were on the higher dose of 14 milligram. So this is the other Pioneer trials, comparing with placebo, comparing with sitagliptin, comparing with empagliflozin, patients who, compared with injectable liraglutide as well, and then patients who had renal failure, patients who were on a flexible dosing based on either the tolerability or their target achieved or not, and then the Pioneer 8 where the patients were on insulin either. In all these groups that up to 5 kilogram weight loss was attained. In some the Pioneer studies less, but average is around 4 to 5 kilograms weight loss, and this is better than the placebo or all the other active comparators. Same in the sustained in change in body weight over time. This is again looking at the study period, whether it was at 26 weeks or 52 weeks. The weight loss was maintained at the 52-week period also. There may be a plateau that is achieved, but the weight loss is sustained if the drug was continued for the whole year. Now, compared to background age, you can see that the older the age group of the patient is, the weight loss is somewhat less compared to the younger age group in the Pioneer 1, 2, and 3 studies, but then the later studies, it wasn't the case. But overall, you can see that regardless of the age, the patients lost weight when they were on the oral semaglutide. Now, this is based on the background medications. Most patients were either on metformin alone. In some studies, the patients were either on metformin plus sulfonylurea combination, and in a couple of studies, the patients were on metformin plus an SGLT2 inhibitor, and in one study, the patients were on background insulin. So, despite being on an SGLT2 inhibitor, despite the patient being on insulin, whatever the background medication was, the subjects who were on the oral semaglutide lost weight. So now this is the change in HbA1c. Again, up to 1.5% HbA1c reduction was seen across the trials when in the group with oral semaglutide compared to either placebo or the other comparator drugs, including sitagliptin, empagliflozin, and injectable liraglutide. Now this is the 2022 ADA standards of care, and you must be very familiar with this particular slide here. We will, instead of focusing on the atherosclerotic cardiovascular disease benefits, we would rather focus on the minimizing weight gain or promoting weight loss part of the flow chart here. And you can see that the preferred drug of choice when the goal is to either minimize weight gain or promote weight loss, the choice of drug is GLP-1 receptor agonist. And if either the glycemic target is not achieved, then you can add on to the second agent, which is most often is an SGLT2 inhibitor or other medications. Now we will move on to the a case study here. So this is Mr. Pawan. He is visiting the clinic for a routine checkup. He's 46 years old. He is a software engineer, and his HbA1c shows that his HbA1c is like 8.1%. He's currently on metformin plus a sulfonylurea combination. His family history includes his mother had diabetes at the age of 46, and his father died of heart attack at the age of 57. Social factors: he's married with 2 children. He has a sedentary job, and he works from a seated desk and often eats sugary snacks. I see many Pawans in my clinic. I bet you all do also. And it may be not be a sugary snack, it may be a savory snack, but we have such patients in our clinic. And like you said, HbA1c is 8.1%. He weighs about 88 kilograms, coming with a BMI of 30 kilogram per meter squared, which is at least a class 1 or a class 2 obesity for the South Indian population. His blood pressure is 142 over 85. Total cholesterol is 189, LDL is 103, and his GFR is 90 ml per minute, 1.73 meters squared. His urine albumin creatinine ratio is still in the mild or normal range, which is less than 30 milligram per gram. And we will look into a downstream approach first, where we say that looking ahead, he is currently on a metformin plus diet plus exercise therapy. He continues to progress in the disease process. We started giving him other medications, and we are trying to prevent complications for him. He comes back 3 years later. We try to do what we usually do. In the lifestyle intervention, even though we ask him to have 150 minutes of exercise per week, he only walks 2 to 3 times a week for about 20 minutes. And he tries to follow a healthy diet, no specific diet, but he tries to follow what's called a quote-unquote healthy diet. Current medications, he's on metformin, 1000 milligram twice daily, and a glimepiride, 4 milligram once a day. And in the past 3 years, he continued to have a sedentary lifestyle, erratic food intake, and he's not able to achieve the glycemic control with the ongoing therapy. And his concerns now, he starts to have some shortness of breath and fatigue over the last 6 months. He's been having hypoglycemic episodes. He's been gaining weight slowly but progressively over the last 3 years. And we know that his father died of a heart attack at age 57, and he's concerned that whether he may follow the similar path here. So you can see that his HbA1c is like almost similar, 8.1 3 years ago, and now it's 8.3. He has put on more weight, he's gained about 3 kilos, and his BMI has gone by 1 kilogram per meter squared now. His blood pressure still remains high, his LDL cholesterol still remains high, and his GFR has fallen a bit, and his urine albumin creatinine ratio has started to go up now. And you can see that in the glycemic control, if you plot them over the 3 years, it's not, he doesn't come very often to the clinic, so we have only HbA1c once a year, and you can see he's like hanging around the 7.8 to 8.3% of the HbA1c. So at the 3-year mark, we make a decision that he needs better treatment. So we start giving him a GLP-1 receptor agonist, and we also wanted to start addressing his cardiovascular benefits. We start giving him a statin. Again, we are talking about a downstream approach here. So now another 3 years goes by. Now he comes back, now being on a GLP-1 receptor agonist, his HbA1c has gone down to 6.8%. His BMI has come down to 28.3. His weight is now reduced. His blood pressure is better controlled. His LDL has come down to less than 100. His GFR is in the range, and his USCR is now back at 30. So this is the downstream approach that we've been looking at since we started presenting this case. He was diagnosed 6 years ago with type 2 diabetes. We started him on lifestyle modifications, diet, exercise, and we started him on metformin. The disease continued to be progressive. I wouldn't see limited efficacy because lifestyle intervention has, that has the greatest efficacy. Metformin also has a very great efficacy, but because of limited compliance and limited surveillance, he continued to have a disease progression. He started developing some cardiovascular complications at the 3-year mark. Then we started giving him the GLP-1 and the statin, and now after a 6-year period since his initial visit, we are able to get him to a better weight, better glycemic control, and lower risk of cardiovascular complications, and we can further manage his cardiovascular risk and complications. Now, if we look back, what can we do? If we had started him on something else earlier on, like say at the time of diagnosis, if we started him on, along with the lifestyle changes, along with the metformin, if we started him on a GLP-1 receptor agonist at the time, and a statin, we could have prevented him much better. It's a more effective drug. He would have lost weight. He would have been had a more better compliance and frequent surveillance, and we could have managed his cardiovascular risk better, and we would have prevented him to progress in the forward pathway of getting more and more complications. So, this is the upstream approach compared to the downstream approach we earlier said. So, bottom line, we know that, in India, the burden of type 2 diabetes is increasing, and this is complicated by the inadequate control and other comorbidities. Body weight is a big risk factor, and it is synergistically it worsens the patient outcome. So addressing the adiposopathy or the weight problem up in the upstream approach at early on will help our patients to have a better clinical outcome. So strategies in weight reduction along with the, either the diet, physical therapy or the medications have some limitations, and that gap can be filled by GLP-1 receptor agonist, which has multiple other pleiotropic benefits, particularly the weight loss part, other than controlling the glycemic approach. So this is the upstream approach we want you to take home as a message that addressing the weight problem early on will be the key to success in our patients, and oral GLP-1s will have a place in that. Thank you.
Thank you, Dr. Thiagarajan, for your insightful and lucid presentation on this particular pioneering the upstream approach. Now, for the benefits of postgraduates, let me tell you, whenever you administer any peptide orally, it is subjected to hydrolysis or degradation. That is, it undergoes degradation because of the acid pH in the stomach. Second thing is, it also undergoes enzymatic degradation, number 2. Third important thing is penetrability, that is permeability within the gastrointestinal tract is much limited. Ultimately, the bioavailability will be very low. So we have this particular formulation, semaglutide, which has been co-formulated with SNAC, SNAC, that is sodium N-hydroxybenzoyl aminocaprylate. So when it is combined with this, automatically it prevents the degradation of this particular semaglutide in the stomach, and ultimately it gets absorbed. That is to say, it enhances the gastrointestinal epithelial absorption, so resulting in a better bioavailability. Second important thing is, it has to be taken on an empty stomach. So Dr. Thiagarajan, he has highlighted nicely our approach with reference to obesity, Indian context, thin fat Indian, lower BMI, higher fat mass. So various measures he has given with reference to 5% loss, 10% weight loss, and 15% weight loss, and the ultimate results. Right. Next is, if you look into the Pioneer 1, 2, all the studies conducted, compared to placebo and the active comparator, oral semaglutide has been associated with rate-dependent reduction in A1C value less than 7%, and weight loss of more than 5%. And higher proportion of patients achieved A1C of less than 7 and weight loss of more than 5%. And very important thing, he has also pointed out nicely, the international guidelines that recommend management of patients with the type 2 diabetes with reference to associated comorbid conditions, because no more glucocentric approach. Hereafter, we should have a patient-centric approach taking into consideration all the comorbid conditions associated with patients with the type 2 diabetes, like overweight, obesity, dyslipidemia, hypertension, with a view to reduce atherosclerotic cardiovascular disease, number 1. Heart failure incidents. Third important thing is development and progression of CKD. Now, the forum is open for discussion. So let me begin the discussion, sir.
Yes.
How will you give a take-away message to the students regarding the administration of oral semaglutide, which is currently available as 3 milligram, 7 milligram, and 14 milligram, and the uptitration also?
Sure, sir. So as Dr. Shanmugam sir said, it's a oral peptide, so it is attached to an absorption enhancer called SNAC, and it has to be given in a very specific way so that the drug is absorbed and the bioavailability gets better. So, as in all other GLP-1 receptor agonists, you always start at a low dose and slowly titrate the dose upwards. So you start with a 3 milligram dose, ask the patient to take the 3 milligram dose in the first thing in the morning on an empty stomach with half a glass of water or 4 ounce or 120 ml of water, however you say it. Better to say it with a half glass of water, and no food or drink or other medications for the next 30 minutes. And then if the patient is able to tolerate the dose for the next, say, 4 weeks, then you move on to the next dose of the 7 milligram. And if the patient is able to tolerate the 7 milligram dose for the next 4 weeks or a month, then you move on to the third dose of the 14 milligram and keep on it. whenever the patient would have any GI intolerance, either it be nausea or vomiting or constipation or diarrhea, try to scale back to the previous dose the patient was able to tolerate without any GI side effects. So that is how you, up-titrate the dose as the patient tolerates. And again, important thing, it has to be given in the specific way so that the bioavailability is better. So you give the dose in the morning on an empty stomach with just half a glass of water and no food or drink for next half an hour.
Thank you, sir. Next is some of the patients, they are taking thyroid replacement tablet number 1, proton pump inhibitor. In case, what is your advice?
Okay, sir. So, as far as the thyroid medication goes, there has been a small study where thyroxine at a supraphysiological dose was given along with the oral semaglutide, and it was noticed that the thyroxine level, the T4 level, went up by 33%. So, you may want to monitor your thyroid function levels after you start the oral semaglutide, and that may be because of the delayed gastric emptying and the slow transit of the GI transit that is actually causing this increase in the thyroxine level. So the approaches can be done is either the thyroxine is given in the first and then half an hour later the oral semaglutide can be given, or you move the thyroxine to a nighttime dose at least 2 to 3 hours after the night meal. So either approach can be done so that the interaction is minimized, but whatever approach you take, you still have to monitor the thyroxine levels. As far as the proton pump inhibitor goes, again a study was done using omeprazole, and again it was done in the healthy subjects, but so that caveat is there, but still their interaction seems to be less and not a significant one. So could be given, but I would prefer still giving the oral semaglutide first and then wait for half an hour and then take the proton pump inhibitor.
So what are the common side effects you come across in your day-to-day practice, and how are you managing?
Okay, so the most common side effect you would be seeing is the GI side effect, particularly nausea and vomiting. Very rarely you might see constipation or diarrhea. As far as the nausea goes, the best way to approach this is to tell your patients that they may expect to have some nausea. So prepare them that they may have nausea, but reassure them this will get better over the next 8 to 12 weeks. So if you tell them that if you bear through the first 8 to 12 weeks, you will be able to get over this side effect and you will be having the benefits from the drug. But if they do have side effects, what you can do is, you can ask them some home remedies such as, chewing on a piece of ginger or a ginger candy in their mouth very slowly to reduce the nausea, just like, any pregnant woman in their morning sickness would do to try to minimize the nausea. Or the other thing is, eat very small amount of food. Very small meals and less fatty meals will reduce the nausea also. And then drink plenty of water afterwards, not in the when they swallow the tablet, but through the rest of the day. And then, if they have significant nausea, then very significant nausea, then you may use medications, and it has been used in the clinical trials also, like such as ondansetron can be given, but I would use it as the last resort approach. And like I said, if the patient is able to tolerate a lower dose prior, and only the nausea gets worse after the dose has been up titrated, then bring them back to the previous dose, keep them on the smaller dose for longer periods of time, and then move up the dose.
Thank you. Dr. Selvaraj, sir, you want to say anything?
Sir, one of the slide you showed there is 2.7 kg weight reduction
Yes.
after using this drug. But I would like to use drugs like empagliflozin, TAPA, and Cana, which also reduces almost 2.5. Instead of spending 300 rupees per day, I spend only 10 rupees to get the same benefit. All the trials show any obese patient need a 10% reduction of weight, of total weight, to get the maximum cardiovascular benefit and glycemic benefits.
Sure, sir. So the particular study that was shown that showed the 2.7 kilogram weight reduction, that was a study in a small percentage of numbers, only 15% of 15 number patients, and they were healthy subjects and type 2 diabetes patients, and they were switched over to the placebo also. And that was more to look at, what is causing the weight loss rather. Is it because of the reduced energy intake or reduced calorie intake? Is the resting metabolic rate changes? And what is the body composition changes? That particular study was done for that, to address those questions. But in all the other trials, the weight loss is like up to 5 kilograms. And, in the Pioneer trials, like you said, most of the Pioneer 1 to 8, some studies showed a weight loss of up to 4.1 kilograms. And in one particular study, it showed up to a weight loss of 5 kilograms. And in clinical practice, you can see that 5 kilogram weight loss is lost for most of the patients, especially when they start with a higher weight, they lose even more weight.
Thank you, sir. Thank you very much for your presentation as well as.
I am Ilangovan.
Yes, sir.
In obese patient after gastric bypass surgery, administration of GLP-1 analogs is likely to cause DPP-4 degradation, prone for recurrent hypoglycemia. What is your experience in this? Gastric bypass surgery, introduction of GLP-1 analogs, we are likely to go for recurrent hypoglycemia due to endogenous insulin release.
Yes, sir. So they, patients who are post-gastric bypass surgery, they already have a higher risk of postprandial hypoglycemia because of the increase in acidoblastosis or the increase in the insulin levels as well as in the GLP levels. So some patients, despite having a bariatric procedure, may not follow the lifestyle intervention and may start gaining weight. In those situations, GLP-1 receptor agonist can be used, but I think there is only limited studies that has addressed that question. In my practice, I have not used it in many of the patients. I have used some injectable GLP-1s in post-bariatric surgery patients, and I have not seen hypoglycemia, but they do have more GI side effects, sir.
Thank you very much.
Thank you, sir, for your excellent presentation as well as good interaction, sir.
Thank
Now
you.
I'll hand over the mic to the organizer.
That was a great start for the symposium tonight. Thank you, sirs, for having shared your knowledge with us. I request Dr. Shanmugavelu to felicitate Dr. T. Tyagarajan for his talk. I also request Dr. Ponnaya to felicitate Dr. Shanmugavelu for chairing this session. Thank you, sirs. I thank Noah Norris for sponsoring this talk. The next talk is sponsored by Shrishti Healthcare, and it will be delivered by Dr. M. Shanmugavelu, and he will be talking about SGLT2 inhibitors, the statins of the 21st century. I request Dr. M. Shanmugavelu to please continue with this talk.
So may I call Srishti RSM to come onto the stage to say.
I also request Dr. M.S. Ashok to chair the session.
My respects to our chairman, Dr. Sedaraman, past chairman, for all come here for this meeting, and my dear postgraduate students. We wish you a very good 2 days of, or 3 days of knowledge, wisdom. By the time you leave on Sunday, I'm sure you would have gained a lot of knowledge. I'm extremely grateful to the organizers to ask me to chair this session of Dr. Shanmugavelu. Although there are so many things about Shanmugavelu to be seen on the screen, I will only wish to tell you that I've been associated with us, all of us, been associated with him from our pre-medical college days. This Trichy Medical College, before it became a medical college, we were all working at the government headquarters hospital. As a physician, we were all doing post-mortem. That was the days in government headquarters. I was attached to Dr. Shanmugavelu. One word is, he is one person who brought the field of diabetology to Trichy. That is the most important thing. He brought the field of diabetology, and people all over India would recognize this Trichy town because of his presence here. And he is the first person to start a diabetic. We have a continuing education here. It's called Diabetes Center of Trichy. And for 12 years, uninterrupted, with the help of so many people here, which I would like to mention all the names here, he started 12 years of non-stop uninterrupted. Every month we have a session. I think all the 12 years, you can count the number of months and the conferences for the last 12 years. And that is his greatness. And the topic is open. I think we will take up this topic. And if you would like to see him for discussion, the best time would be after 11 o'clock in the night till 2 o'clock in the morning.
Respected chairperson, senior doctors, my doctor friends and members of the pharma company, I feel extremely happy, honored and most privileged to have been invited to make a presentation on SGLT2 inhibitors, the statins of the 21st century, with a particular focus on evidence and outcomes. I thank chairperson for his nice introduction, also thank the organizing committee members for having given me a golden opportunity to share my views on this particular topic. My disclosures, what I'm going to do for another 20 minutes, SGLT2 inhibitors, the statins of the 21st century. So type 2 diabetes is a multi-causal, heterogeneous, progressive cardiometabolic condition. It's a major risk factor for atherosclerotic cardiovascular disease, heart failure, and CKD. Despite major therapeutic advances leading to improved outcomes over the past 2 decades, cardiovascular disease remains the leading cause of morbid mortality in patients with the type 2 diabetes. So accordingly, the development of treatment strategies to improve cardiovascular, heart failure, and renal outcomes in this vulnerable patient population remains a major priority. So the progressive complexity of type 2 diabetes translates into need to modify and individualize anti-hyperglycemic agents in order to improve glycemic control and also delay the advancement of the disease. Newer agents proven to reduce adverse cardiovascular, heart failure, and renal outcomes in these patients with the type 2 has triggered a major paradigm shift beyond glucose control to a broad strategy of comprehensive cardiovascular risk reduction. So SGLT2 inhibitors, the statins of the 21st century. This particular statement was issued by the Harvard Medical School, and subsequently it was endorsed by Braunwald. That is, a small number of drugs have been responsible for major advances in medical practice. So the discovery, development, and elucidation of the mechanisms of actions of aspirin, penicillin, and statins are remarkable success stories, each with some surprises and each crowned by a Nobel Prize. SGLT2 inhibitors have been proven effective in the treatment of type 2 diabetes, various forms of heart failure and kidney failure, and represent one of the major pharmacological advances in cardiovascular medicine in the 21st century. Can we vote for it? Can we accept? Let me take you all through my shorter presentation. Before we accept this particular statement issued by Harvard Medical School and endorsed by Braunwald. If you look into the prevalence of cardiovascular disease in patients with the type 2, so 7.6% stroke, myocardial infarction, heart failure, coronary artery disease, and overall cardiovascular disease. So this results show that cardiovascular disease is the major cause of comorbidity and death among patients with the type 2 with the CAD having the highest prevalence. So prevalence of CKD risk in Indians with the type 2 diabetes based on I Care for Diabetes, and this particular clear list shows the prognosis of CKD by eGFR and albuminuria categories as well as CKD risk with reference to percentage of patients, low risk, moderate risk, high risk, and very high risk. So this is a very important article that was published in 2019. This particular article clearly confirms that is the legacy effect in patients with the type 2 diabetes. Recent literature confirms that strict glycemic control less than A1C is less than 7, in the first year significantly reduces the risk of microvascular events. So 39% reduction in microvascular, 29% reduction in macrovascular, and 29% reduction in the death. That is, patients with A1C less than 6.5 versus between 7 to 8 in the first year. So the key message, intensive treatment for newly diagnosed patients might be necessary to avoid irremediable long-term risk for diabetes complication and mortality. So thin fat Indian phenotype highlighted by Dr. Tyagarajan. So thin fat Indian, high visceral fat, high insulin resistance, early decline of beta cell function, and very important, there's high risk for diabetes-related complications. So glycemic efficacy, patient with SGLT2, this was meta-analysis based on the ORCTs, clearly shown the fact that SGLT2 inhibitor, that is the response, is stronger in Asian patient with the type 2 compared to DPP4, and differences in response are more likely to reflect phenotypic or pathophysiological changes. Next is ominous octet. 8 factors contributing to overall patient with hyperglycemia. So if you look into the SGLT2 mechanism of action, it acts predominantly in the renal tubules. And very important thing, it has got indirect action as well as direct action. And direct action also includes increased glucagon secretion as well as increased endogenous glucose production, and besides other actions also. These are all the challenges with reference to Indian patients. Low adiponectin level, high insulin resistance, high triglycerides, low intact GLP levels, and enhanced DPP4 activities. And we have the relevant SGLT2 inhibitors with features. It improves adiponectin level, reduces insulin resistance with a favorable impact on lipid profile, strengthen GLP response, and suppress DPP4 activities. So this is a very important slide. Patient with the type 2 diabetes, they have, there is reduction of glucose reabsorption when SGLT2 inhibitor is given. Glucose excretion in the urine is very much reduced. That results in caloric loss, reduction of body weight, and very important thing is this alters the insulin glucagon ratio and reduction of excessive insulin secretion with a positive impact on liver, adipose tissue, as well as skeletal muscle. Ultimately, it improves the insulin sensitivity, reducing insulin resistance. Same thing, increased urinary glucose excretion, reduction of the insulin, and with a favorable impact on the beta cell function, that is in terms of glucose-stimulated insulin secretion, upregulation of the genes responsible for insulin biosynthesis as well as glucose transporters, and amelioration of islet morphology, and with the preservation of beta cell function and mass. So this is the ultimate metabolic changes following inhibition of SGLT2 with reference to adipose tissue. There is a substrate switch from glucose to ketone with reference to cardiac myocytes as well as skeletal muscles. Next is with a favorable impact on liver as well as kidneys, reducing glucose as well as adipose tissue. SGLT2 increases fat utilization by causing upregulation of FGF21 in the liver, and also by activating the AMPK in the skeletal muscles. Also, it improves the thermogenesis, enhances browning of white adipose tissue, ultimately resulting in energy expenditure and reduction in body weight as well as ectopic fat accumulation. SGLT2 inhibitors, again, if you look into this NLRP3, a pyrine domain, and which stimulates the interleukin 1 beta and favorably induces atherogenesis. And SGLT2 inhibitors inhibits NLRP3 and thereby the release of interleukin. Next is epicardial fat, the fat that is located between the visceral pericardium and the endocardium. Myocardium. And this epicardial fat that results in inflammation, oxidative stress, and results in increased atrial fibrillation. By putting the patient on SGLT2 inhibitor, it reduces the epicardial adipose tissue. It reduces inflammation, it reduces oxidative stress. Multiple channels are upregulated and multiple channels are downregulated in patient with the diabetes, and SGLT2 inhibitors improves some of the channels and reduces the incidence rate of atrial fibrillation. Again, sympathetic activity. It restores the tubular interstitial burden and reduces the renal afferent nerve. And very important thing is it reduces sympathetic outflow to the heart, to the blood vessels, as well as to the kidneys. In the kidneys, it reduces the action mediated by renin-angiotensin aldosterone action. And next is reduces the neprilysin action. In turn, favorably upregulates natriuretic peptide with the impact on the vascular compliances, reduces the volume load, wall stress, and also the fibrotic changes in the myocardium. These are the SGLT2 inhibitor mediated BP lowering effect in that it induces diuresis, elimination of salt sensitivity, reduces body weight, decreases uric acid levels, and decreases the sympathetic nervous system activity, arterial stiffness, and favorable impact on the hemodynamic mechanism. Next is SGLT2 inhibitors reduces hepatic fat content. in patient with the type 2 diabetes, non-alcoholic fatty liver disease. A significant difference was found in liver fat. Next is significantly improved biomarkers of hepatic steatosis and fibrosis in patient with the type 2 diabetes and non-alcoholic fatty liver disease. So it has a favorable impact on the fatty liver index as well as the fibrotic markers. Next is possible histological improvement in patient with NASH when patients were given empagliflozin. Next is it also improves the obstructive sleep apnea, sleep apnea index, and nearly 52% lower risk of new onset obstructive sleep apnea in EMPA outcome trial. This particular slide clearly shows the deposition of fat in the retropalatal as well as retroglossal region, as well as increased muscle mass, which causes pharyngeal edema or pharyngeal narrowing, increasing the risk for obstructive sleep apnea. By reducing the fat mass and by reducing the muscle mass, it results in improvement in obstructive sleep apnea. Patient with congestive cardiac failure, when they assume a recombinant position, there is a rostral shift of interstitial fluid that results in pharyngeal edema and predisposition to obstructive sleep apnea. And SGLT2 inhibitors, by virtue of its differential impact on interstitial compared to blood volume, that is intravascular volume, it offers significant relief. Right. Next is cardiorenal implications of SGLT2 inhibitions, diabetic cardiomyopathy. So diabetes, through hyperglycemia, hyperinsulinemia, insulin resistance, and multiple other mechanisms, lipotoxicity, glucotoxicity, and various intracellular pathways, it ultimately results in cardiac myocyte apoptosis, fibrosis, left ventricular hypertrophy, greatly increasing the risk for diastolic function and diastolic failure. So maladaptive pro-inflammatory response furthers the progression of diabetic cardiomyopathy. So patient with the type 2 diabetes, already hemodynamically overloaded state. And second important thing is metabolic overload state. This ultimately results in inflammation, oxidative stress, energetic disturbances, ionic disturbances, in turn results in mitochondrial cytopathy, vascular dysfunction, contractile dysfunction, cell death, and failure. This is a very important slide. That is patient with the type 2 diabetes. There occurs glucotoxicity, lipotoxicity, accumulation of dysfunctional organelles within the cell, and that results in endoplasmic reticulum cells, oxidative stress, and inflammation. Normally, this is removed by a process called autophagy. This autophagy mechanism is impaired in patients with type 2 diabetes. So enhanced nutrient and oxygen deprivation signaling, that enhances autophagy, it improves glycemic control, ATP production, and restores mitochondrial cytopathy as well as endoplasmic reticulum stress. So SGLT2 inhibitors, by enhancing nutrient deprivation signaling, it induces reduction of oxidative stress, prevention of organelle dysfunction, suppression of pro-inflammatory pathways, and activation of autophagy. Thereby, it slows down the development and progression of cardiomyopathy and nephropathy. These are all the plausible mechanisms for SGLT2 inhibitor associated cardiovascular benefits: reduction in the interstitial edema, reduction in pre and after load, and improvement in renal function and cardiorenal physiology, inhibition of cardiac sodium hydrogen exchanger, and improved cardiac bioenergetics. So SGLT2 inhibitor differentially impact the interstitial and intravascular column compartment so that it relieves signs and symptoms of interstitial congestion, provide relief of elevated cardiac filling fracture, and prevent harmful effects of excessive blood volume loss. So intravascular volume loss, that results in hypotension and ultimately leads to development of cardiorenal syndrome. Next is NHE1, that is expressed in cardiac myocyte, that ultimately increases the cytoplasmic sodium and calcium, reducing the calcium in the mitochondria. By putting the patient on SGLT2 inhibitor, it improves the calcium within the mitochondria, thereby it improves the mitochondrial function and cardiac myocytes. The same thing, vascular effects. It improves nitric oxide activity and vasorelaxation. It improves the viability of endothelial cells and improved mitochondrial function. Next is EMPA, given in this particular trial, may reverse left ventricular remodeling. That is, it reduces the left ventricular mass index and left ventricular extracellular volume fraction. Dapagliflozin in declectomy, risk of atrial arrhythmia was significantly reduced compared to patient treated with the placebo. I told you the multiple mechanisms are operating in patients with the diabetes, increasing the risk for atrial fibrillation and ultimately the stroke incident as well as cardiovascular death. Again, EMPA reduce the risk of arrhythmias or sudden cardiac death in patients with the type 2 and established cardiovascular disease. In patients with the type 2 diabetes and atherosclerotic cardiovascular disease, these trials have clearly shown EMPA, DAPA or canagliflozin, when given, associated with significant impact on MACE, cardiovascular death, all-cause mortality, hospitalization for heart failure, as well as chronic kidney disease outcomes. So as per statistical robust meta-analysis, heart failure with reduced ejection fraction, patient with diabetes, patient without diabetes, if you look into the composite of cardiovascular death and hospitalization heart failure, robust reduction observed in both the groups of the patients. This is an emperor preserved study design where the left ventricular ejection fraction is greater than 50% when given, that is compared to placebo. Empagliflozin demonstrated a meaningful 21% relative risk reduction in the composite primary endpoint of cardiovascular death. Again, reduced the first and recurrent hospitalization for heart failure by 27%. And this represents the first therapy with conclusively proven benefits in patients with heart failure with preserved ejection fraction, regardless whether the patients have type 2 diabetes or not. So, emperor preserved, you see the primary endpoint, see the result, nearly 21% relative risk reduction compared to other trials, including the sacubitril/valsartan combination or spironolactone compared to placebo or irbesartan or perindopril or candiceton in other trials. That means giving this particular drug can have a beneficial impact on patient with preserved ejection fraction failure. Deliver, again the largest and broadest trial to date in patient with left ventricular ejection fraction greater than 40%, significantly reduce the risk of cardiovascular death or worsening heart failure in patient with left ventricular ejection fraction greater than 40%. That is the primary endpoint. Next is with full population, left ventricular ejection fraction less than 60, again robust reduction. So wide range, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, significant reduction in the composite of CV death or worsening heart failure in patient with the ejection fraction less than 40% or greater than 40%. That is very important, regardless of the ejection fraction, regardless whether the patients have diabetes or not. It has resulted in robust reduction. Again, significantly reduced mortality and hospitalization for heart failure across the range of left ventricular ejection fraction, death and hospitalization for heart failure, CV death, all-cause death, and first hospitalization as well as total hospitalization drastically reduced. Again, decoding EMPA. So most possible cascade mechanism of EMPA in heart failure with preserved ejection fraction. That is upstream effects, reduces cardiac myocyte oxidative stress inflammation, and downstream effects cardiac myocyte stiffness, extracellular matrix remodeling, and concentric hypertrophy. So EMPA directly improves diastolic function in human heart failure. So overall, ACLT2 inhibitors, by reducing preload, afterload, it improves the cardiac contractility, cardiac function, improved cardiac structure and function. So this is a very important slide. Estimated clinical benefit in reduced ejection fraction. So see the top panel, ARNI plus beta blocker plus mRNA plus SGLT2. That is 4 novel drug therapy for the management of reduced ejection fraction. Compared to other, without any of this, you can see the mortality rate. So CV mortality hospitalization, when you prescribe all the 4, there was significant robust reduction. Next is new expert proposal for sequencing of heart failure with reduced ejection fraction. So simultaneously start step 1, a beta blocker plus SGLT2 inhibitor. Step 2, over a period of 1 to 2 weeks, ARNI, that is sacubitril/valsartan, and step 3, MRA, melanocorticoid receptor. When you prescribe all the 4 drugs, over a period of 4 weeks, low dose, it will definitely improve the outcome. Diabetic kidney disease. So I have given the healthy kidney and diabetic kidney disease. There is increased reabsorption of sodium and glucose in the proximal convoluted tubule. There is proximal tubular inflammation and fibrosis. And very important thing is small amount of sodium is sent to the distal convoluted tubule. So that results in alteration with reference to tubular-glomerular feedback. Kidney protection with SGLT2 inhibitor. So more amount of sodium is delivered to the macula densa. It restores the tubular glomerular feedback. Not only that, it reduces the proximal tubular inflammation and fibrotic changes with a favorable impact on the renal outcome. This is in short, that is changes of the microenvironment that causes transformation of fibroblasts within the renal cells into myofibroblasts, and that is associated with the decline in the erythropoietin. By putting the patient on ACLT2 inhibitor, the cortical tubular interstitial damage decreases and erythropoietin production is restored. That improves hypoxia with a favorable impact on other renal outcomes. So it improves the kidney outcomes in patients with the type 2 with a consistent kidney benefits across different albuminuria levels. So we have the MACE. Similar to MACE, we have the major adverse kidney events. You can see the improvement. So among patients with the type 2, EMPA use was associated with EGFR preservation, greater decline in BMI, and reduced risk of MACE compared with other non-ACLT2 antihyperglycemic agents. Again, use results in 58% lower risk of serious kidney events in patients with and without diabetes. So in this analysis, using nationwide data from 3 countries, ACLT2 inhibitors compared with the DPP4 was associated with a significantly reduced risk of serious events. So the proposed renal protective pathways include reduction in blood pressure, direct cardiovascular effect, reduces intraglomerular pressure, improvement in glycemic parameters, next is loop diuretic like action, and ambient pro-inflammatory, pro-fibrotic pathways. It improves oxygenation of tubular cells and reduces the albuminuria. So ACLT2 agents have demonstrated clinically meaningful kidney outcomes even in studies involving patients without type 2 diabetes. So EMPEROR, DAPA-CKD, DAPA heart failure, which involve patients without diabetes, there was significant improvement in renal outcomes. EMPA kidney trial stops early due to evidence of efficacy. If you look into the summary of results, treatment effect was demonstrated regardless of underlying cause of CKD. Regarding the underlying cause of CKD, in patients with diabetes and without diabetes, a significant 14% reduction in all-cause hospitalization seen with EMPA that is impactful for patients, care providers, and hospital admissions. So again showed clinically significant reduced risk of incident and recurrent nephrolithiasis. These are all the ACLT2 inhibition which improves hemodynamic parameters in patients with the type 2 leading to cardiorenal. So in the heart, next is cardiorenal protection in the kidney as well as in the circulation. Right. So please remember, this particular article was published in JAPI, Mangesh Tivashka, euphoria, vascular euphoria. U stands for endothelial function improvement, utilization of energy substrate, pressure and volume offloading, hemo concentration, oxidative stress, reverse LV modeling, inflammation control, and autonomic balance. So priorities for holistic care in patient, risk factor control, that is improvement of glycemic control, taking into consideration body weight, obesity, and taking into consideration EGFR albumin excretion, blood pressure lowering, lipid lowering, and identification of the risk factors for atherosclerotic cardiovascular disease, taking into consideration metabolic parameters, cardiac parameters, as well as renal parameters. So let us come back. ACLT2 inhibitors, the statins of this 21st century. Right. Let us confirm. Right. First paradigm shift. That is, findings were soon confirmed with CANA and DAPA based on the reports of EMPEROR outcome trial. That was the first trial which clearly showed patients with the type 2 diabetes with established cardiovascular disease. There was significant reduction in cardiovascular death, all-cause mortality, as well as other 3P MACE. Next is second paradigm shift. There followed 2 trials of patients with a history of heart failure with reduced ejection fraction with the DAPA and EMPA, both of which showed equal benefits in patients with and without diabetes. That is second paradigm shift. Next is third paradigm shift. That is in 2021, the EMPEROR Preserve trial extended the improvement in outcomes in patients with preserved ejection fraction failure to patients without diabetes, leading to the third paradigm shift. Next is fourth paradigm shift. Trials of ACLT2 inhibitors in patients with the type 2 diabetes, reduced ejection fraction, combined with the 2 trials of patients with the CKD that included patients without diabetes, exhibited substantial significant rate of production, leading to fourth paradigm shift. So the researcher recently posed a question: could flozins be the statins for risk-based primary prevention of heart failure? What can we say? can now be answered affirmatively. Thank you very much for your kind listening.
Thank you, Dr. Sanmavelu. The house is open for discussion. I think he has come. Dr. Rajshekar, please.
Thank you very much, Sanmavelu, for a very nice talk as usual. And so you said that can be used in obstructive sleep apnea, it's oral fat reduction. Like that, any non-diabetic individuals, only for the sake of reduction of weight.
It's
like
a
obesity
very
or obstructive
it's a
sleep
very
apnea,
relevant question.
can it
It's a
be
very
used?
relevant question. So obstructive sleep apnea, the patients they have taken into for statistical data analysis, patients participated in EMPERAC outcome trial, and when they examined, that is when they assume a recommend position, there is rostral shift of the fluid that causes pharyngeal edema, narrowing of the airway, and causes worsening of the obstructive sleep apnea. When those patients were given SLT2, the resultant outcome was remarkable. And subsequently, they have gone into the details regarding the tongue anatomy. They look into the fat mass or the tongue muscle mass. And this is one of the explanation, that is regression of the fat mass as well as the muscle mass can also improve the pharyngeal airway.
But can it be used in non-diabetic?
No, sir. No.
That's
As of now, it is not an approved indication for the management of obstructive sleep apnea. So patients who are receiving this particular drug for the management of that is type 2 diabetes with atherosclerotic cardiovascular disease, it is an incidental finding.
Thank you.
I request the postgraduates to schedule inhibition and please come forward because this symposium.
Dr. Manivasakam, yes, I'm happy to, yes.
Good evening, friends. As usual, Dr. Shanmavelu is giving a very fantastic lecture. In his TDSC, he has got one lecture hall, Sam GP Moses lecture hall. The way in which he presents cases, slowly he is transforming to Sam GP Moses style.
Verbal diarrhea.
Exactly. Regarding gliflozins, that is SGLT2 inhibitor, even though any student can tell that heart failure with preserved ejection fraction, there are only 3 drugs. Number 1 is MRA, number 2 is ARNI, number 3 is SGLT2 inhibitor. But when we go into the guidelines properly and thoroughly, they say in the guideline, the ARNI and MRA can be given in heart failure with preserved ejection fraction at the lowest level of ejection fraction. According to the various studies, the lowest level of ejection fraction cutoff is 55. That means when the ejection fraction is less than 55, your ARNI and MRA will act. The only drug as on 2022 which will act irrespective of ejection fraction, it can go up to 70% of ejection fraction. This SGLT2 is the only drug. This is for the information of the postgraduates. Thank you very much.
Thank you, Dr. Arambi. Thank you so much for endorsing Brownwald's statement. Yet another cardiologist from Trichy also endorses the same.
Do you have any preference between these drugs, DAPA, GANA?
No, sir. No, sir. No. No preference at all. No preference at all. Although after the publication of EMPERAC outcome trial, EMPER was primarily prescribed to minimize the cardiovascular death all-cause mortality, and subsequently if you look into all the meta-analysis, it has been proved to be a case of class effect rather than pertaining to a particular molecule or drug.
But still it remains as a second-line drug.
Which one, sir?
For the use of diabetes, anti-hyperglycemic effect, it still remains a second-line drug.
No, sir. So it can be prescribed even without metformin also. Whenever you see a patient presenting with heart failure, presenting with multiple risk factors for atherosclerotic cardiovascular disease or established cardiovascular disease, or presenting with urinary albumin excretion more than 200 milligram, if EGR is adequate, appropriate, you can prescribe as monotherapy. You need not put the patient on metformin.
Please, the postgraduates, please come forward. Schedule.
Pardon, sir?
See,
your EGFR is less than 20. These SGL2 drugs lose their effectiveness as anti-hyperglycemic drug. Am I correct, Dr.
Yes, sir.
Sandhu?
Yes, sir. Yes, sir. Of course.
But still, empagliflozin and DAPA can be used in 10 milligram dose for cardiovascular and renal benefits.
That is EGFR up to 20 ml. You can prescribe safely with a view to improve the cardiovascular and renal outcomes. Regarding remogliflozin, there is no data with reference to long-term cardiovascular, heart failure or renal outcome.
Is there any adverse effect of these drugs?
Adverse effect we come across early in the beginning. Some of the patients, they present with the genital mycotic infections or urinary infection. That's all. Otherwise,
Post-surgical?
that is depends upon the usage. So post-surgical means we need to give sufficient time, let the patient become stable, then you can start prescribing.
Madam, please.
Good evening, sir. I am Dr. Geeta. எனக்கு ஒரு சின்ன டவுட் தான். இப்போ சப்போஸ் the statins of 21st century நம்ம சொல்றோம்னா, like it should have been compared with any of the statins like rosuvastatin or atorvastatin.
Sorry,
But
it is I'll tell you.
ஒரே ஒரு நிமிஷம் சொல்லி முடிச்சிடுறேன். லைக் பட் இது வந்து ஃபுல் அண்ட் ஃபுல் வந்து பிளாசிபோவோட தான் பண்ணியிருக்காங்க. ஸோ பிளாசிபோவோட எந்த ட்ரக்குமே வந்து பெட்டராக தான் இருக்கும் நேச்சுரலி. அது இன்னொன்று வந்து மெட்டானாலிசிஸில் நம்ம பார்த்தம்போது எல்லாமே பிளாசிபோ ட்ரையல்ஸோட மெட்டானாலிசிஸ் தான் வந்திருக்கு. இன்னொன்று வந்து ரிலேட்டிவ் ரிஸ்க் ஆர்ஆரை வச்சு தான் நம்ம சொல்ல முடியும் இட் இஸ் பெட்டர்னு. பட் ஹசார்ட் ரேஷியோ இஸ் கம்பேரிட்டிவ்லி ஆர்ஆரோட ஆர்ட்ஸ் ரேஷியோட கம்மி தான் நம்ம வந்து இது சிக்னிஃபிகன்ட் சொல்கிறதுக்கு. ஸோ அதனால் வந்து மேபி நம்ம இன்னும் பெட்டர் ஆர் இன்னும் பிக்கர் மெட்டானாலிசிஸ் வச்சு தான் அது ஸ்டாட்டின்ஸ்னு நம்ம சொல்ல முடியுமோ அப்படின்னு எனக்கு தோணுது. It's open for discussion.
The thing is, statins we prescribe not only for reducing or lowering lipids, but also it has a pleiotropic effects. Pleiotropic effects. So patients with type 2 diabetes, LDL cholesterol may be normal, still we continue to prescribe. That is, each and every patient should receive. That is number one. Second thing is, why it has been compared? Statin with a proven impact on overall morbid mortality as well as cardiovascular, cardiovascular events. Similarly, it has brought. See, when you compare the duration of statins in the market, comparing the duration of the SGLT2 in the field, it is only for a short period of time. Just to say the same effect we are getting, so why not we say it is the statins of the 21st century?
Hello. Sir, I am Dr. Ramaswamy, physician. I have been using these SGLT inhibitors for quite some time. Though we see a lot of fungal infections associated with this SGLT, but my question to you is, how many cases of euglycemic ketoacidosis you came across, sir, and what is your experience?
Pardon, sir?
Euglycemic ketoacidosis.
Euglycemic ketoacidosis I have not come across because I carefully select my patients before I prescribe. I normally educate my patients before I prescribe. So I have not come across any patient with euglycemic. But I happen to see this euglycemic ketoacidosis when it was prescribed by some other doctor. Okay? Thank you.
Thank you, sir, for updating us with the latest information thereof.
Thank you so much.
I now request Dr. M.S. Ashok sir to felicitate Dr. M. Shanmugam sir for his talk.
Yes, I'm happy to answer Dr. Murali, endocrinologist. Yes.
I am from Chandigarh, endocrinologist. Very wonderful lecture, Dr. Shanmugam, as usual.
Thank you.
This is just for the postgraduates because you rightly said that you have to choose the patient in whom you use the drug. And as was rightly pointed out, any EGFR more than 20, it is indicated when the setting is in congestive cardiac failure. And even in non-diabetic patients, that's why now we feel that cardiologists and nephrologists are prescribing it much more than even diabetologists. But my point is, you have to stratify the risk of, we are not bothered about genital infections, but urinary infections. If somebody has prostate enlargement, or in long-standing diabetes when there is cystopathy, where you have residual urine in the bladder, recurrent UTIs, which many women are already predisposed to in postmenopausal period, and in the setting of heart failure, when you are already using ARNI, another diuretic, plus mineralocorticoid receptor antagonist. When you add SGLT2 inhibitor, we have to be very careful about their hydration status because their GFR can worsen, especially in elderly patients when their intake is poor during summer or when they are hospitalized. That's why your point is very well taken that in hospitalized patients, it's always better to withhold the drug temporarily. These are my...
Yes, sir. Thank you, sir. Thank you very much.
Thank you, Dr. Shanmavelu.
No, already got it. Already got it. I got it.
Very good evening. Myself Sheikh Kader, Area Manager based at Trichy, Sanofi Diabetes Insulin Team. So I would like to take this opportunity to welcome you all for this today's session, and also I would like to thank the organizing committee of Trichy API for giving this wonderful opportunity to deliberate this lecture today. So once again I take this opportunity to introduce our today's chairperson for this topic. Today's topic going to be the tackling of prion hypoglycemia. So glycemic variability and time in range with second generation basal insulin 2.0, that is Tojo. So I would like to welcome our chairperson to take the contacts and introduce our today's speaker for this topic. So as you know very well, Dr. A. Sedaraman doesn't need any introduction. Sir has worked as a professor in Trichy Medical College, so most of you know by his name. So I don't think he need any introduction further. Sir, over to you, sir. Now you can introduce our today's speaker and set the contact, sir. Over to you, sir.
Thank you very much for the organizing committee and for the Sanofi India company. Without wasting time, there are so many things going on about happening, new things. For example, the diagnosis of diabetes, now this thing, it's ominous act like that means something serious thing is going to come. Like that, pathophysiology is also changing. Something new drugs also coming. Something new monitoring systems. Like as you all know, what from SMPG to CGMS to what there are so many other methods. That is glucose watch, by which you can monitor the glucose for 24 hours, like your pulse oximeter. So many things. So what is the advantage of using all these things to maintain the glycemic control, so that you can manage the diabetes and also prevent the occurrence of complications. Here is our man, Dr. Caesar, who is going to talk about the long-lasting, long-term in use of insulin. So you all know we are celebrating the 100 years of insulin. So the diabetic management means the one drug which is the last 100 years, not only 100 years, and latest insulins, as I told you, newer things, there are once a weekly insulin like Igodec, once a weekly semaglutide, like that, so many things, something new coming. So like that, how you can monitor the diabetes and how you can manage, that is time in range. Then GCMS and SMPG, like that, by monitoring such method, how you can better manage with the latest, the U300 or latest, the second generation insulin, basal insulin, and that is why we are here to listen to Dr. Caesar. Caesar is the consultant physician diabetologist, and from Tanjavur, Caesar is attached to Caesar's Diabetes Specialty Center and New Sugam Medical Center, Tanjore. He is a consultant physician diabetologist at Caesar Diabetic Specialist, and MBBS from PhD Institute, Coimbatore, MD from Stanley Medical College, and PhD Diploma from Annamalai University, and 5 years worked as assistant professor in Tanjore Medical College, life member of as usual AP, RCD and EASD, regional faculty for CCED, PDM, PHFI, regional faculty for National Diabetes Education Program for training paramedical person in the field of diabetes. So published articles in national and international.
Let us listen to Dr. Caesar, how they think, what the latest insulin, the second generation insulin, how it helps to monitor and manage the diabetes. Over to you, Caesar.
Thank you, sir. At the outset, I'd like to thank the organizing committee of TAPICON Trichy for giving me this wonderful opportunity and the chairperson for introducing me. Good evening, everyone. The topic today given to me is like tackling the triune of hypoglycemia, glycemic variability, and time in range in respect to that of the second generation basal insulins. My agenda of talk for the next 20 minutes will be on these 4 bullets. 1, to talk about the concept of glycemic variability and time in range and their clinical implications. 2, about the review of the global recommendations regarding this glycemic variability and time in range, addressing the hypoglycemia, the glycemic variability and time in range with basal insulin therapy, comparing the second generation basal insulin analogs in respect to the light of time and range. Coming to the first agenda, we know that conventionally we were talking about the triad of glycemic control. So whenever we want to have a glycemic control, we used to have the concept of having a good control of fasting glucose, postprandial values and HbA1c. And from this triad, we have definitely switched over to the hexad, which includes not only the fasting glucose values, your postprandial and HbA1c. The 4th parameter comes your hypoglycemia, 5th one the nocturnal, and 6th definitely the glycemic variability. So just addressing towards fasting, postprandial and HbA1c may not enough in a long run. You need to address towards the other 3 parameters also, which includes the overall hypoglycemia, nocturnal hypoglycemia, of course the glycemic variability. So what is this glycemic variability? How do you define it? So it is nothing but which refers to the fluctuations in the blood glucose levels of either peaks and troughs. And this glycemic variability can be of either way. It can be an intraday or it could be interday. So how do you measure or how do you metric this glycemic variability? There has been plenty of parameters how you would assess the glycemic variability. For example, for an intraday, what we conventionally use is the standard of deviation or coefficient of variation by your continuous glucose monitoring or even SMBGs. For inter-day variability, along with the standard deviation and the coefficient variation, the gold standard for measuring the glycemic variability will be a MAGE, otherwise the mean amplitude of glucose excursion. So why this glycemic variability is important? Because this glycemic variability can lead to high oxidative stress, subsequently leads to the increased risk of severe hypoglycemia when not properly addressed. They can lead to both extremes of hyper as well as hypoglycemia, which in long term can produce ill effects in the outcome of the patient. So the high glycemic variability is associated with diabetes related complications as well as the poor quality of life of the diabetic patients. We know that this glycemic variability is associated with the definitive markers of endothelial and cardiovascular damage in diabetic patients, and particularly in patients with type 2 diabetes who ends up with an acute myocardial infarction. The incidence of otherwise the mortality rate as well as the outcome of the patient is poor whenever the patient tends to have increased visit-to-visit glycemic variability. So whenever the patient has more glycemic variability, the patients with type 2 diabetes mellitus, when they end up with an acute myocardial infarction, they are more prone for an increase in the mortality as well as the overall outcome is poor in those patients compared to that of the patients who have got a lesser glycemic variability. Not only the cardiovascular things, patients with type 2 diabetes having a high glycemic variability has been associated with cognitive impairment also. So establishing the glycemic variability, it should be addressed even when you have got an adequate target of HbA1c. That means even when you got a controlled HbA1c, even in those patients, you have to have an emphasis on addressing towards the glycemic variability, because different patients having same HbA1c of 7 or less than 7 can have different phases to it. One set of patients can have a very low blood glucose values or time in range. The other set of the patients can have 50%, the other set can have 60%, but still all these patients can have the same HbA1c. So just controlling the HbA1c alone may not be adequate nowadays. A patients having a good control of HbA1c still can have a poor glycemic variability, and that should also be addressed to have a overall better outcome in patients. So time in range and what's above and below the time in range. So time in range is nothing but it is defined as the time spent in the target glucose range. For example, it can be like 70 to 180. This target is individualized, it's not the same 70 to 180 in every case. So overall, we take 70 to 180 as the range. So it is the amount of time, otherwise the percentage of the time, what the patients stay in this target value of 70 to 180, while definitely aiming at reducing the time spent in hyperglycemia as well as hyperglycemia. So time above range is anything the amount of time what the patient spends above the 180, and this can be categorized as level 1 hyperglycemia if the patient glucose values, otherwise the time stays between 180 to 250, and it is labeled as level 2 hyperglycemia if the glucose values are more than 250. Likewise, whenever the patients tend to have the glycemic values less than 70, they are labeled as time below range. And in this time below range is also level 1 is said when it is between 55 to 70, and level 2 is when the patients have a glucose values of less than 54. So what are the outcomes you get if the time in range is not maintained? So a 10% derangement in time in range can lead to a 64% increase in the risk of retinopathy, a 40% increased risk of nephropathy, and 24% increased risk of neuropathy. So the initial evidences also show not only towards the microvascular complications, the surrogate markers of macrovascular complications like the abnormal carotid intermediate thickness also are worsened whenever there is a derangement in the time in range. So we do have a time to change towards the time in range. Even though the usage of the continuous glucose monitoring started in the years of early 2000, there has been no definitive consequences regarding the time in range or the metrics by which it can be measured. The Helmsley Charitable Trust first formed the expert panel in the year 2012 in the aim of proposing a definitive CGM metrics to have a definitive address towards the patients in regard to the time in range. And in this 2012 came the first concept of the time in range where they were defined properly. Subsequently, systematic approaches to CGM data was evaluated, and it's gained momentum in the year 2017. Even though various forums were formed, the expert committees were formed, still there were no unified recommendations regarding the targets of metrics which should be used in the continuous glucose monitoring. So with this in context, in 2019 came the ATT, otherwise the Advanced Technology and Treatment of Diabetes Forum, where they formed the definitive metrics for measuring the glycemic variability as well as the various metrics which can be used in continuous glucose monitoring. And they came to the consequences in 2019. So in 2019, in the ADA supplement, they have recommended the continuous glucose monitoring might increase the treatment satisfaction and increases the time in range, and it has been advocated to be used in patients whenever it is needed or indicated. The AAC and AC in 2020 also recommends that CGM assist in reaching the glycemic goal safely by even preventing the higher incidence of hypoglycemia, which has been subsequently endorsed in 2020 as well as in 2021 by ADA. And CGM has been used as an important tool for hypoglycemia prevention nowadays. So if you look for the ATT 2019 recommendations, for the time in range for different diabetic populations, as I said, it's not the same time in range which is kept for everyone as we have for HbA1c. So since we have an individualized goals for glucose values, including your HbA1c, the time in range is also individualized depending upon the patient's scenario and the condition. For example, patients with type 2 and type 1 diabetes, the time in range is kept as the target range of 70 to 180, and the range of time target is kept around 75% in TAR, and the time above range has to be restricted to less than 30%, where the level 1 time above range, otherwise the patient's glucose value less than 250 to be kept around 25%, and it should not exceed 5% above 250 milligrams, otherwise level 2 hyperglycemia. Likewise, your hypoglycemia, otherwise the time below range, the level 1 has to be kept at less than 4% and level 2 less than 1%. This is for overall type 2 as well as the type 1. But when the patients are older or got a higher risk or at-risk patients, the same criteria doesn't apply here, where the target of target range, otherwise the time in range, is kept around 50%, not the same 70 as that of the general population. And the level 1 hyperglycemia, otherwise the time above range, is kept less than 50%, and the time above range of level 2 is kept below 10. The level, otherwise the time below range, is kept less than 5 in all these categories. For pregnancy, if it is the type 1 patient who is going for pregnancy, then the target range, the time in range itself, not the percentage of time in range, the target range itself is revised to not 70 to 180, it's kept between 63 to 140. It should be more stringent. And even with this value of 62 to 140, the time in range should not exceed 70%. And the time above range should not exceed more than 25%. It should be less than 25%. And that should also be less than 140, not like 180 or 250 as we see in the general population. For gestational diabetes or pregnancy-induced diabetes, where the target range is the same as that, where you try to keep the target value of in between 63 to 140, and the time above range should not exceed more than 10%. So even though the time in range is not the same for every individual, it should also be individualized according to whether the patient is a high-risk patient or general population, or the patient has got a GDM. And not only according to this, the expert panel recommendations from the 15 countries, including India, states the time and range has to be addressed according to the age group of the patients, whether the patients are adolescents, adults, pregnant, or elderly. As I said, it's not the same target time in range for every individual, and the time in range has also been addressed according to the patient's age group. So not only the patient age group, it also has to be looked for whether the patient has got other complications like hepatic or renal disease, whether the patient has got an existing microvascular complications, people with concomitant infections, or people with macrovascular complications. So the target values and the ranges also has to be altered and changed accordingly whether the patient has got other comorbid illnesses. So we really have a suboptimal clinical utilization of time in range. So despite its demonstrated values, time in range is seldom used in our routine clinical practice. So as time in range is important, but it's seldom measured, so why not go for treatment solutions which take care of time in range, even though not continuously monitored by us? So can insulins address this time in range? So almost amongst insulin, which one will definitely address towards the time in range better? So the basal insulins can effectively address hypoglycemia, glycemic variability, as well as the time in range. We know that glycemic variability happens either because of the peaks of glycemic values or the troughs. The peaks which are caused by the glycemic excursion can be predominantly by even your postprandial glucose values. Basal insulins can effectively control even the postprandial glucose excursions by hitting the base of the fasting. As it comes down, automatically your postprandial also comes down. It may not address specifically to postprandial values, but still the postprandial values also comes down when you address towards the fasting. So the basal offers the flexibility of using the PPG targeting OADs, which can be used along with the existing OADs also. The troughs, definitely they can be addressed because caused by hypoglycemia during the interpandral period. So there is a lesser risk with your glargine when compared to that of your NPH, and there is a lesser risk of hypoglycemia with glargine when compared to the premix or the co-formulations. So why this is important? Because even a minor hypoglycemia erodes the patient's confidence on taking the insulin. Hypoglycemia is the most common and the third adverse effect of insulin therapy and the greatest barrier to the maintenance of normal glycemia. We know that almost 1 in 5 patients with type 2 diabetes achieve HbA1c less than 7% even with the insulin therapy. 2 in 5 patients with type 2 diabetes reduce their insulin dose after a minor episode of hypoglycemia, and 77% of the patients who experience hypoglycemia within 6 months of their insulin initiation had discontinued their therapy within a period of 1 year. So it insists on the importance of preventing the hypoglycemia, particularly in the early stages of initiation of insulin. So this is where the second generation basal insulin comes to help a hand. So they evolved keeping these in mind. We know that in the past, the evolution of history of the basal insulin started with the NPH insulin in 1946. The first generation basal insulins like your insulin glargine 100U and insulin detumer were developed to overcome some of the limitations which they had with the NPH insulin, with less variable absorption and longer duration of action. But subsequently, even that was not enough, and they were not also able to address all the benefits of the basal insulin. And there came the second generation basal, otherwise longer acting basal insulins, including your insulin glargine 300 as well as the insulin degludec 100U, which has been developed with less variability and more prolonged of action, more than 24 hours. So I'm going to highlight a few studies to have a backup of the importance of having a good glycemic variability. The first one is the BRIGHT study, which is the first head-to-head clinical trial comparing the glargine 300U versus that of insulin degludec 100. A dose titration the first weeks after basal insulin titration initiation is critical for achieving the glycemic targets. And this study was to look for the non-inferiority of the glargine 300 versus that of degludec 100 in the reduction of HbA1c. In this study, you know that in respect to the HbA1c, there is no much difference between both the glargine 300 as well as insulin degludec, but the difference comes in the outcome of hypoglycemia. If you look into the comparison of both the second generation basal insulins, the overall incidence of hypoglycemia is almost similar for both your glargine 300 as well as that of your insulin degludec, but the incidence rate of the nocturnal confirmed hypoglycemia were definitely better with your glargine 300 in comparison of the degludec in this particular study. So there was a lesser risk of hypoglycemia with glargine 300 compared to that of insulin degludec 100 during the most critical phase of the insulin, that is the titration period. And early hypoglycemic events during the titration are associated with the increased rates of treatment discontinuation as well as the long-term risk of hypoglycemia. So glargine 300 may offer an advantage in hypoglycemia risk reduction when compared to that of degludec 100 during the titration period in insulin-naive patients with type 2 diabetes. So let us examine how the second generation basal insulin addresses the glycemic variability and help people to be in range of glycemic control. This is one of the, as shown in the figure, the fluctuations of the smooth and insulin infusion rate over 24 hours was significantly lower with the glargine 300U when compared to that of the insulin degludec 100U at 0.4 units per kg dose level. Glargine 300 provides a less fluctuating steady state pharmacodynamic profiles and more evenly distributed pharmacokinetic profiles compared to that of insulin degludec 100 in a once daily morning dose regimen with 0.4 units per kg body weight. And this is another independent PKPD study which showed that there was a 22% greater insulin peak with the insulin degludec when compared to that of glargine 300, and there was a 23% lesser within day variability with glargine 300 versus that of insulin degludec. This is another CGM study in type 2 patients to compare the time in range when the patients were either used with glargine 300 to that of insulin degludec. The objective of this study is to compare the efficacy and the safety of glargine 300 and degludec on glycemic control using the continuous glucose monitoring. The patients were randomized. It's a crossover study with 30 type 2 patients once daily, whether to put on glargine 300 or degludec. And the efficacy endpoint was to look for the mean percentage of the time within the target glucose range of 70 to 80. So the mean percentage of time within the target glucose range was not different between either the insulin glargine 300 or insulin degludec. The figure displays the average daily glucose profile for 3 consecutive days measured using the continuous glucose monitoring. The glucose variations were similar in all the 3 participants. So however, the mean percentage of time of hypoglycemia with insulin glargine 300 was significantly lower than that of insulin degludec. In the secondary safety endpoints, the mean percentage of time of severe hypoglycemia or nocturnal hypoglycemia with glargine 300 was also significantly lower when compared to that of glargine degludec 100. So the difference is, even though the efficacy was not much of difference, even though the time in range was similar in both the categories of the patients, the incidence of hypoglycemia, particularly the nocturnal hypoglycemia, was less in the limb of patients who were put on glargine 300. So here is the same study with the usage of your flash glucose monitoring, comparing the time in range for glargine 300 to that of insulin degludec 100. 30 patients with type 2 diabetes were randomized once daily either to glargine 300 or to degludec. As I said, the primary efficacy to look for the efficacy and the secondary endpoints to look for the safety, including the hypoglycemia. There was a significant lower nocturnal hypoglycemia with the glargine 300 compared to that of insulin degludec. The OneCare is the real-world evidence study in patients with type 1 diabetes using CGM, comparing glargine 300 to that of degludec 100. Adults with type 1 diabetes switched from the first generation basal insulin analog to glargine 300 or degludec within a period for 24 months. The primary endpoint was to look for the percentage of the patients in the TAR, and the secondary endpoints to look for the percentage of time above range, time below range, and of course the safety of hypoglycemia was also looked into it. The study showed a similar time in range, time above range, and time below range profiles for both glargine 300 and insulin degludec, but the differences was in favoring glargine 300 for time in glargine 300. The conclusion of the real-world study showed the effectiveness and safety of glargine 300 was similar to degludec 100 in those switching from the first generation basal insulin. However, more patients on glargine 300 got a with time in range in the night, particularly compared to that of degludec 100. Even though the overall time in range was comparable between the two categories, the time in range, particularly the nocturnal period, was better on patients who were put on glargine 300 compared to that of degludec. So the in-range study is on another comparative study of the second generation basal insulins analogs glargine 300 versus that of degludec in persons with type 1 diabetes using the continuous glucose monitoring. If you look for the study design, it's a multi-center head-to-head comparative study comparing glargine 300 to that of degludec 100U in a large sample size using CGM for 20 consecutive days. So the glargine 3 in the study showed that glargine 300 is non-inferior to degludec 100 in people with type 1 diabetes in terms of glycemic control and in terms of glycemic variability, with no differences in the occurrences of hypoglycemia and safety profiles. So with this in background, to summarize, I would say glycemic variability and time in range is associated with the increased risk of severe hypoglycemia, diabetic complications, and reduced quality of life. As glycemic variability and time in range is important, it's seldom measured. It is recommended to go for treatment solutions which take care of time in range even though not regularly monitored. The second generation basal insulins demonstrated lesser risk of hypoglycemia and improved glycemic variability and time in range than other insulin regimens. Among the second generation basal insulins, glargine 300 had demonstrated lesser risk of hypoglycemia during the titration period and a better glycemic variability and time in profiles. Thank you very much for the patient hearing. Over to the chairperson.
Thank you very much, sir, for your nice lecture. Actually, we have been usually do asking blood sugar, postprandial blood sugar, HbA1c. That is commonly we do in all patients. But to assess the glycemic status, really you need to do what your CGMS, by which you can assess time in range, whether it is below or above, where you can really diagnose. Okay. So by doing time in range and also what glycemic variability and also the nocturnal or anytime hypoglycemia can be assessed by your CGMS. So, but this is the one which is, though it is cost effective, cannot be afforded, afforded by all many people, can be useful really to assess at least in ICU setup or in patients who are having dysglycemia. So the open forum is open to question. Any clarifications? Before starting, Caesar, I want to know, is it the only way of what CGMS needed to assess this time in range or any other method? Because our patients, everyone cannot afford to go for CGMS.
So time in range is assessed by CGMS.
So we routinely do SMBG.
then this thing nowadays CGMS and all these
So you
things we
can
are doing it.
assess
Any other possibilities?
So definitely you can assess glycemic variability even with the usage of your SMBG, but time in range has to be measured with your
Only by
CGMS.
CGMS.
That how often you do this time in range in pregnant ladies?
So nowadays we have started using it, sir. Even though it's not often, definitely it started using it.
So in response to the question raised by Dr. Seduraman, A1C is a gold standard, but it has its own limitations.
Yes,
SMPG, again, no problem at all. But the thing is, we do it when the patient is awake. But it is a nocturnal hypoglycemia we need to recognize, which is practically not possible with SMPG. So that can be detected with CGMS, continuous glucose monitoring. We have poor man's continuous glucose monitoring also. That is, you measured 7 times glucose profile for 3 days continuously, and you can plot it. It more or less resembles that of CGMS. But CGMS is different, SMPG is different, and A1C is different. And again, continuous glucose monitoring, this data TAR gets translated in terms of the microvascular complication as well as macrovascular complications. So each technological innovation, improvement measured has its own values.
Is there any studies supporting that, sir?
Sir, the latest articles are highlighting the importance of CGMS and TAR.
First of all, congratulations, Caesar, for a nice presentation.
Thank you, sir.
Now we talk about time and range in very many things. Anticoagulant, for example, hypertension. Actually, time and range is important for hypertension also. Somebody will have normal blood pressure in the daytime. They may have nocturnal hypertension. So you have to choose a drug. What is the importance of time and range? You should have a drug which covers 24 hours. Suppose if it covers only the daytime, the diurnal variations we cannot find out. So time and range is applicable nowadays in the anticoagulants, also in the hypertension. If the time and range is not there in diabetic management, these people are more prone to develop macro and microvascular complications. That is the importance of time and range. Sooner this will come, and all the drugs should have time and range. Whether it is hypertension, whether it is epilepsy, whether it is anticoagulants. So this is what now revolutionizing the therapy. So I think everyone should be aware about time and range, especially the drugs in the pediatric type 1 group. If the patient doesn't have time and range, they go for nocturnal hypoglycemia. Same way, nocturnal hypertension is dangerous in hypertension. Thank you.
Thank you, sir.
So in office practice, traditionally fasting and postprandial blood sugar is measured and HbA1c is measured, sir. In office practice, what other blood sugar measurement will you advise?
Pardon, sir, I don't get your question, sir.
See, traditionally we measure fasting blood glucose, postprandial blood glucose, and HbA1c for checking control, sir. But in office practice, to assess the time in range, there is a time in range. What other blood glucose timing you advise?
So
see,
time
in office practice, Dr. Singh said 7 times you measure for that is closely similar to continuous
time in range definitely
monitoring.
it's a time in range can be assessed with the usage of your continuous glucose monitoring, sir. Not with the routine lab standards. So ideally look for, even though as I said, if you look for a glycemic variability is intraday can also measured even with the help of your self-monitoring of blood glucose, where you can even do a standard deviation as well as coefficient of variation.
Sir, how many times will you advise to measure the blood glucose? But that's a point, sir.
No. There are 2 parts. As I said, if you want to exactly look for the time in range, it has to be done with the help of your continuous glucose monitoring. As I said, for glycemic variability, if you want to look for glycemic variability without the help of CGMS, then you can do a SMBG, and in that also it can be done to look for the inter-day glycemic variability with the help of a CGMS, where you can do the standard deviation as well as coefficient of variation with the various values of SMBGs, like the 7-point testing you do. That's how we can do it, but to exactly look for the percentage of time in range, it can be done with the help of CGMS only.
For the benefit of postgraduates, I am telling, This basal insulin addressed only the fasting plasma glucose. So whenever there is a high fasting plasma glucose, it will address, you will reduce. But since diabetes is a progressive disease, after some time there is a postprandial spike. This will not address, this basal insulin will not address. You need a short-acting insulin during this spike.
If not any more questions, the carry-home message actually, diabetic management monitoring not only your fasting blood sugar or postprandial blood sugar or HbA1c, the triune, that is what triune means, 3 in 1, which is what your time in range and glycemic variability and hypoglycemia, that is all together. These 6 can be easily addressed by us what our what lecture, the new generation basal insulin, that you can take it. Thank you very much.
Thank you, sir.
Thank you, sir. I also thank Symposium Limited for sponsoring this talk. For the next talk, sponsored by Zydus Healthcare, I invite Dr. M. Sindharaja to the rise to deliver his talk on immunity, novel agent and type 2 diabetes on theory with dual benefits. I also request Dr. Shanu sir, please come to the rise to start the session.
So good evening to all delegates. On behalf of Zydus Life Sciences, I thank the organizers of TAPICON 2022 for giving us an opportunity in this scientific symposium on imiglamin, the novel agent in T2DM armamentarium with dual benefits. I also take this opportunity and request Dr. Shanmugavelu sir to chair this session and also introduce the speaker and take it forward. Thank you.
Back to Pavilion. Respected and dearest all, it's a happy occasion for me to take you all through a new product, imiglamin, novel agent in the management of patients with type 2 diabetes with the dual benefits. We know, I told you, it's a multi-causal heterogeneous progressive disease. The progressive nature is one of the major challenges. Right. Patient with the type 2 diabetes, basic underlying pathophysiological mechanism is beta cell dysfunction. Whether this beta cell dysfunction results primarily from defect of beta cell function or defects of beta cell mass or both. So if you look into the literature, clearly shown, demonstrated the fact that hyperglycemia, that is glucotoxicity, hyperlipidemia, that is lipotoxicity, both can cause inflammation, oxidative stress, ultimately resulting in mitochondrial dysfunction, endoplasmic reticulum cells, as well as accumulation of unfolded protein. Is there any medication which can improve the mitochondrial function? In terms of mitochondrial bioenergetics, in terms of mitochondrial, the respiratory chains, that is complex 1, 2, 3, 4, modulation of its functions. Is there any drug which can improve the mitochondrial function and the glucose-stimulated insulin secretion? Is there any drug which can improve insulin secretion by improving the mitochondrial function, at the same time improving the mitochondrial function in the liver as well as improving the mitochondrial function in the skeletal muscles, thereby it improves the insulin sensitivity? For this, may I invite Dr. Sindharaja, endocrinologist, graduated from CMC Vellore, currently doing endocrinologist practice in Salem, to take us through your presentation, sir. Over to you.
Thank you, sir, for the introduction. Good evening, all. So, our next 20 to 30 minutes will be going through the new molecule imiglamin. As we all know, India placed second in the diabetes population. In 2021, almost 74 million people are living with diabetes. When it is projected to 2045, almost is doubling. Almost 124 million people will be living with diabetes. When the world census is taken, 1 in 11 adults are having diabetes, and it will increase up to 783 million by 2045. In Southeast Asia, by 2045, almost from now baseline, the diabetes population will increase by 68%. So that is a quite alarming data. So India, in the league of most diabetes cases, it ranks second next to China. Now in 2021, and even if it is projected after 30 years, 2045, 20 years also, it plays second next to China. So 1 in 11 adults have diabetes. India accounts for 1 in 7 of all adults living with diabetes worldwide. The number, as I already told, the number, when we are seeing the projection by 2045, the percentage will increase by almost 69%. The diabetes is responsible for greater than 7 lakh deaths in 2021. So what are the challenges we are facing in type 2 diabetes management? So one is beta cell dysfunction and another is insulin resistance. So what is this beta cell dysfunction? So normally if there is hypoglycemia, the beta cell should sense the hyperglycemia, then only the appropriate insulin secretion will be there, then the hyperglycemia will be controlled. So the beta cell dysfunction results from inadequate glucose sensing to stimulate insulin secretion. So why these beta cell insults are there? So because of obesity, what happens? There will be a glucose as well as lipotoxicity. So what happens? There will be more free radical generation. At the same time, there will be more pro-inflammatory cytokines. So that will increase more insulin resistance. At the same time, it will accelerate the beta cell apoptosis. So at the same, this glucolipotoxicity will cause both insulin resistance as well as beta cell apoptosis. So insulinopenia also will be there. At the same time, insulin resistance also will be there. So the progressive decline of beta cell function leading to beta cell excursion precedes the beta cell demise. So as already told, this because of the glucolipotoxicity. So what happens? There will be more free radical generation like superoxide radicals. So that will damage the mitochondria as well as the beta cells. And at the same time, these free radicals will cause epigenetic changes. This also will lead to insulin resistance and these complications of diabetes mellitus. So this mitochondria plays an important role in pathophysiology of diabetes mellitus. So what are the mechanisms that can lead to insulin resistance? So as already told, because of the glucolipotoxicity, so there will be more free radical generation that will damage the mitochondria. And because of the impaired fatty acid oxidation also, again, there will be more free radical generation. And because of this glucolipotoxicity, there will be unfolded protein response from the mitochondria and endoplasmic reticulum. So what happens? Normally, this unfolded protein response, initially if the damage is small, it will attempt to repair. But if the damage is excess, what happens? It will promote the apoptosis of the cells. So if there is hyperglycemia or if there is deranged lipid parameters, all this will create the inflammation and more free radical injury. So if it exceeds, what happens? This unfolded protein response will be stimulated too much, so it will promote the apoptosis of beta cells. So what happens? The beta cell mass will come down, so thereby it results in insulinopenia. So we'll be going through what is the importance of mitochondria in the pathophysiology of diabetes. So as we all know, mitochondria is the powerhouse of the cell. So it's important for ATP production. So what happens? This ATP is the key regulator for insulin secretion. So as we all know, in the beta cells, once glucose enters inside the cell, ATP will be generated. This once in the intracellular ATP rises, what happens? This ATP sensitive potassium channels will be closed. So that will lead to depolarization. That will increase the intracellular calcium. So that will stimulate the exocytosis of insulin secretory granules. So ATP is very important in the secretion of insulin. So during the past decades, evidence has shown that mitochondrial function is closely related to various facets of diabetes in pancreatic beta cell dysfunction, insulin resistance, obesity, and complications of diabetes. So whatever the agents that are currently available till now, it will address the various omnious octet pathways involved in the pathophysiology of diabetes, but none of the agents will act in the mitochondria to decrease the free radical generation. So why this molecule is developed? The need of the hour is a drug with dual mechanism of action that is designed to increase the insulin secretion in response to glucose, and at the same time it has to improve the insulin resistance. So the simiglimin belongs to a group of tetrahydrotriazine compounds. So it's approved for type 2 diabetes initially in Japan in 2021. It's also approved by DCGI. It's supported by numerous preclinical and clinical studies. Mainly this time study, these trials of imiglimin for efficacy and safety. Till now, times 1, times 2 and time 3 results are there. So this is the only oral compound with a dual mechanism of action that is directly designed to both to increase the insulin secretion in response to glucose and to improve the insulin resistance. It's a new class with a differentiated mechanism of action. So it simultaneously targets 3 organs in diabetes: pancreas, liver and the muscles. So it acts in the pancreas at increased insulin secretion in a glucose dependent manner. In the muscles and the liver, it inhibits the gluconeogenesis, and at the same time it increases the it inhibits the gluconeogenesis, and in the muscles it improves the insulin sensitivity. So we'll be going through how it acts. So as already told, ATP is very important for the secretion of insulin. For ATP generation, as we all know, NADH is necessary, very important for generation of ATP through the respiratory chain. So if there is limited availability of NADH, so there will be limited ATP generation that will again impair the secretion of insulin. This imiglimin, what happens? This NAMPT, this nicotinamide phosphoribosyltransferase transferase. This is the rate limiting enzyme for synthesis of NADH. So this imiglimin stimulates NAMPT enzyme, thereby it increases the generation of NADH. So ultimately this increases in secretion of ATP. So once ATP is intracellular ATP is high, ultimately what happens? This ATP sensitive potassium channel will be closed. Again, it will lead to secretion of insulin by increasing the intracellular calcium. So in this way, it stimulates beta cell to stimulate insulin secretion. And how it acts in the liver? As already told, in the liver it inhibits gluconeogenesis. So there are multiple putative pathways that have been proposed. So it partially inhibits complex 1 in the respiratory chain, and it restores complex 3 function, and it prevents this MPTP opening. This is the permeability transition port. As already told, this unfolded protein response. If there are more excess free radicals, what happens? This unfolded protein response will be stimulated. That will open this permeability transition port that will stimulate the apoptosis. So it prevents MPTP opening. So by all these mechanisms, it inhibits the gluconeogenesis, and in muscles, it improves the uptake of glucose by increasing the expression of transcriptional coactivator termed as peroxisome proliferator activated receptor gamma coactivator. So thereby in the liver, it stimulates glucose uptake in the muscle. So to summarize the mechanism of action of imiglimin, it inhibits the oxidative phosphorylation. In oxidative phosphorylation, what happens? More protons will be generated. Again, it will create more free radicals. So by decreasing the free radicals, it will prevent the beta cell apoptosis, and it modulates the mitochondrial function and structure. So thereby it increases insulin sensitivity, and it inhibits the hepatic gluconeogenesis, and it increases the insulin secretion. And as already told, mainly it reduces the reactive free oxygen species. Thereby it has antioxidant effect. So these are the possible molecular mechanisms by which imiglimin improves the glucose homeostasis. Whatever that I have told previously, it improves insulin sensitivity in the muscle. In the liver, it inhibits hepatic gluconeogenesis. It increases the beta cell function in murine models, and it increases the mitochondrial function, and it decreases the oxidative stress. So how it improves insulin sensitivity? So there are multiple pathways that have been proposed. It can promote the insulin signal transduction by increasing the AKT phosphorylation. Although the underlying mechanisms is not clearly understood. The potential mechanisms include the GLUT4 expression and modulating insulin receptor substrate phosphorylation. So this is the 18-week phase 2 efficacy trial. So in this study, they have assessed both insulin resistance as well as this insulin secretagogue effect. So you can see here when compared to placebo, this insulinogenic index is better with imiglamin, and at the same time, this insulin resistance, the stem wall index is also better with imiglamin when compared to placebo. So in this double-blind randomized placebo-controlled trial, which was conducted in 33 patients who were drug naive, the type 2 diabetic patients, or who have withdrawn from their previous therapy. So in these patients, imiglamin was given for 7 days. So they have assessed the insulin secretory response. So imiglamin improved the beta cell glucose sensitivity by 36% and it decreased hepatic insulin extraction. Imiglamin did not affect the glucagon secretion. So in patients with type 2 diabetes, imiglamin improves the beta cell function, which may contribute to its glucose lowering effect. This study is a retrospective study. In this, they have assessed the CGMS. So whether how much the time in range is spent with imiglamin and compared to placebo. This study was conducted among 32 patients. The study was conducted for 4 weeks. You can see with CGMS, many metrics can be calculated. You can see the mean glucose before imiglamin was 160, after almost decreases by 20 milligram per deciliter. Both coefficient of variation and time in range is better after imiglamin therapy when compared before imiglamin therapy. Here you can see here, this is a continuous glucose profile. So before imiglamin, you can see that glycemic excursions are there. After imiglamin, the blood glucose levels are reduced. Coming to this pharmacokinetic and pharmacodynamic data, it's available as oral formulation. It can be administered twice daily. It's available in 500 mg formulation. We can go up to 1000 milligram twice daily. And it has very low protein binding and it has negligible hepatic metabolism. It is excreted unchanged in the urine like metformin. So even though it's excreted unchanged in the urine, so dose modification has to be done according to the creatine clearance. No significant drug-to-drug interaction, no QT prolongation. The half-life is 13 hours. As earlier told, it's not metabolized. It's eliminated unchanged in the urine. In renal patients, if GFR is greater than 45, you can prescribe with full dosage. If it is less than 55, you should reduce the dose to half, 500 mg twice daily instead of 1000 milligram twice daily. In GFR less than 15 patients, 15 ml per minute, 500 milligram with longer dosing interval is suggested. So no clinical trials have been conducted in patients with moderate or severe renal dysfunction using efficacy and safety as indicators, and administration is generally not recommended if GFR is less than 45. And in hepatic patients also, in moderate hepatic impairment, it's safe and well tolerated, and clinical trials have not been conducted in patients with severe liver dysfunction, and in pregnancy and lactation, it's contraindicated. We will be going through the 3 phase 3 trials, times 1, times 2 and times 3 trial. So initially this is the phase 2 study. This is to study the dose efficacy of different doses. In this phase 2B study, the different formulations has been studied, 500 mg, 1000 mg and 1500 mg. You can see at 500 mg, the HbA1c reduction is 0.5% when compared to baseline. With 1000 mg, it's 0.9. And 1500 mg, the HbA1c reduction is 1%. This is the times 1 trial. This is a randomized, double-blind, placebo-controlled monotherapy trial. So this was conducted over a duration of 24 weeks, conducted in almost 213 Japanese patients. One group placebo, other group received 1000 milligram twice daily. So you can see here in the graph, so after treatment with imiglamin for 24 weeks, from baseline you can see the HbA1c reduction almost 0.8%. So times 1 trial was observed to meet its primary endpoint with a statistically significant HbA1c reduction when compared to placebo. Again, safety and tolerability was good and similar to placebo. And again, this is the times 2 trial. In times 1, imiclomine monotherapy versus placebo. In times 2 trial, this imiclomine is compared with already existing oral anti-diabetic agents. This is a 52-week open label parallel group trial. This was conducted in almost 700 Japanese patients. In this trial, 1000 milligram of imiclomine was administered twice daily in combination with existing anti-hyperglycemic agents. In this trial also, the HbA1c reduction, they have shown that ranging from 0.5 to 0.9%. The maximum HbA1c reduction was seen when it is used in combination therapy with DPP-4 inhibitor, almost 0.9%. Almost with every agent, there is a good HbA1c reduction. So imiclomine was observed to demonstrate robust efficacy benefits when it is combined with DPP-4 inhibitors. And in time 3 trial, this imiclomine is compared with insulin. So this is in this trial there are 2 phases. In the first phase, this is a 16-week double-blind placebo-controlled randomized trial. Almost they have included 215 patients. So again after 16 weeks, they have extended to 36 weeks. So initial 16 weeks, what happens? One group received insulin with placebo, and the treatment group received imiclomine with insulin. And again, what the next 36 weeks, both groups received insulin as well as imiclomine. So you can see in this, almost in each group there are almost 100 participants in each group. Here also you can see here, when compared to the placebo group, there is almost 8.8% HbA1c reduction from baseline. You can see here in the initial 16 weeks, in the placebo group received only insulin with placebo, and the active group receives imiclomine with insulin. So there is a significant HbA1c reduction when compared to placebo group. So with insulin therapy also it can be prescribed. There is a good HbA1c reduction. So this open label extension period showed a sustained mean HbA1c decrease from baseline of 0.6% in patients receiving imiclomine for 52 weeks. There was a HbA1c reduction of 0.54% in patients receiving imiclomine and insulin for the last 36 weeks only. And this is unpublished data conducted in Indian subjects. This is a randomized multicentric double-blind parallel group placebo-controlled trial. So the primary efficacy endpoint is mean change in HbA1c from baseline to end of the study visit. That is 16 weeks. Secondary efficacy endpoints are the mean change in fasting plasma glucose, mean change in postprandial plasma glucose, proportion of patients requiring rescue medications. So almost you can see here, at the final visit, almost there were 100 and the study period was conducted over a period of 112 days. So you can see here, when compared to placebo, the HbA1c reduction, you can see here, there is almost 0.7% HbA1c reduction in the treatment group when compared to placebo group. When the fasting plasma glucose is taken, when compared to placebo, there is almost 13 milligram per deciliter reduction in fasting plasma glucose when compared to baseline. And the postprandial plasma glucose is taken into account. Almost there is 30 milligram reduction in plasma glucose when compared to placebo. And when adverse effects are taken, it's almost negligible when compared to placebo. So imiclomine 1000 milligram was superior to placebo tablets in Indian subjects. There were no deaths or hospitalizations in both the treatment groups. Imiclomine hydrochloride 1000 milligram was found to be safe and well tolerated in patients with type 2 diabetes. Adverse effect is the hypoglycemia. When it is used as monotherapy, when it is used as the 500 mg, the hypoglycemia rate was 1.3%. When it is used in 1000 mg or 1500 mg formulations, the hypoglycemia rate is 1.4%. But when it is used with insulin or other agents like insulin secretagogues, the hypoglycemia rate increases up to 6.7%. So when we are prescribing other agents, the dose of other oral anti-diabetic agents has to be reduced in order to avoid hypoglycemia. Other side effects are very negligible when compared to placebo. So when compared with other anti-diabetic agents, so metformin only it improves insulin sensitivity. It does not act on the beta cells. As we all know, sulfonylureas and this DP4 inhibitors and all, it acts on the beta cells to stimulate insulin secretion. And this imiglamin, it has both. It improves insulin sensitivity and at the same time, it stimulates insulin secretion. So how it differs from metformin? So imiglamin differs from metformin in that imiglamin is a competitive inhibitor of complex 1 activity of the respiratory chain and restores a complex 3 function. Whereas metformin, it stimulates AMP kinase activity. It has insulinotropic effect and also there is no risk of lactic acidosis with imiglamin and compared to metformin. Metformin inhibits mitochondrial glycerophosphate dehydrogenase and causes pyruvic acid to be converted to lactate, which may accumulate to toxic levels in certain situations. However, imiglamin is not this mitochondrial glycerophosphate dehydrogenase inhibitor, and therefore the safety concern does not arise with its use. So, to see the posology of this imiglamin, it's available in 500 milligram tablet formulations. We can give up to 1000 milligram twice daily. It's now approved only for type 2 diabetes. It's contraindicated in pregnancy, lactation, and pre-conception, and it's not approved in type 1 diabetes or secondary forms of diabetes. If GFR is less than 45, it's better to avoid. And significant hepatic dysfunction, it's contraindicated. And as already told, it has not no significant drug-to-drug interaction or drug-food interaction with this agent. So, what are the indications? If other drugs are contraindicated or considered to have adverse risk-benefit ratio, example, if patient is elderly, renal insufficiency, or if there is isolated fasting hyperglycemia, we can initiate with this agent. If other drugs are not well tolerated, for example, if there is gastrointestinal side effect or risk of acidosis, if there is risk of weight gain or hypoglycemia, we can give a trial of this imiglamin. If in the intensification phase also, patient is already on oral 2 or 3 oral antidiabetic agents. For intensification of therapy also, it can be added. So to summarize, so type 2 diabetes is a widespread disease affecting more than 380 million people worldwide. Currently, there are 2 challenges in type 2 diabetes management. One is insulin resistance and another is beta cell dysfunction. So beta cell dysfunction results from inadequate glucose sensing to stimulate insulin secretion, therefore elevated glucose concentrations prevail. Insulin resistance is characterized by diminished response to insulin stimulation, resulting in the failure of target tissues to adequately dispose blood glucose. So mitochondrial dysfunction also plays an important role in type 2 diabetes. So currently available oral anti-diabetic agents address only one facet of type 2 diabetes. Imiglamin, it addresses both insulin resistance as well as it stimulates insulin secretion. So it targets 3 organs of diabetes: pancreas, liver, and the muscles. So this imiglamin has been shown to have a positive impact on skeletal muscle glucose uptake. It inhibits hepatic gluconeogenesis and it prevents beta cell apoptosis. So in monotherapy as well as in combination therapy, it has demonstrated good efficacy. So thank you all for the patient listening.
Thank you, Dr. Sindhil Raja, for your nice presentation on imiglamin. Imiglamin is a novel, first-in-class oral antidiabetic drugs with a distinct mechanism of action. Namely, it improves the mitochondrial energetics, mitochondrial function, modulates the respiratory chain. And next is, it improves the glucose-stimulated insulin secretion. One. Second important thing is, it improves the insulin action by altering the intracellular insulin signaling pathway, both in the liver as well as in the skeletal muscle, to be given twice daily. The recommendation is 1000 milligram twice daily as monotherapy or in combination, and maximum efficacy was observed when it was prescribed with DPP4 inhibitors. Care to be taken while prescribing along with the sulfonylurea or insulin in view of risk of hypoglycemia. That's regarding the overall pharmacokinetic and dynamic profiles of the novel agent. Now the forum is open for discussion.
No, sir, no head-to-head comparison. Sir, actually, this glimepiride only, it's insulin secretagogue. It only acts in the beta cells. Whereas the simiglimin, it stimulates beta cells, it acts on the beta cells to promote insulin secretion, and in the liver it inhibits hepatic gluconeogenesis, and in the muscle also it promotes the glucose uptake. So it targets the 3 organs. Sir, it is used as monotherapy ranging from 1.3 to 1.4%. When it uses combination therapy, up to 5 to 6% in trials it has been reported.
Sir, actually, glimepiride, it's a secretagogue. Its mode of action is totally different. Imiglamin, its mechanism of action is totally different. It primarily acts intracellularly, that it improves the mitochondrial cytogenetics. Yes, doctor?
I'm also one of the CHAD alumni of CMC, so nice to see you.
Thank you.
And in this study, it's phase 3, right? Phase 3.
Yeah, phase 3 trials.
So that means the new drug has to be compared with the standard treatment, right?
Yeah.
But in the study phase 3 trial of times, they have done with placebo, like insulin and placebo versus insulin and imiglamin, right?
Yeah.
And I think that is the problem.
Yeah, this compare with insulin.
Compared with metformin.
No, it's not like that. Insulin is also one of the oral anti-diabetic agents. Yeah.
Insulin,
So then.
Insulin is a standard treatment.
Yeah.
But we are comparing. This is a superiority trial or a non-inferiority trial?
No, this is like non-inferior, not non-superior. It's like to compare the efficacy only. So it's not designed to prove non-inferiority. That's to demonstrate the efficacy and compare with insulin.
The efficacy of this drug, imiglamin, it has to be compared with either metformin or any other oral diabetic agent instead of a placebo, even though both the arms they have insulin in common. So I think it's
maybe
better,
in times 2 trial it has been compared. So maybe they times 3 they want to evaluate when it is used in combination with insulin alone.
So
That's it.
Because why I'm saying that is this drug is not fit for the lower eGFR. That's what you said.
Yeah, absolutely.
So that means metformin we are not giving for low eGFR also.
Yeah, less than 30 it's contraindicated.
So
Yeah.
the ideal is to compare another oral diabetic agent or any other diabetic agent in that term with insulin and this newer drug and insulin in another.
Yeah, maybe in renal impairment subjects it can become, but maybe in future studies will come. Only 3 trials are available and one in Indian subject, that's an unpublished data. So a few more trials will answer. Okay. Thank you.
Madam, the thing is, these are all short-term studies conducted with a view to assess the efficacy, number 1. Number 2, tolerability. Number 3, safety aspect. That they have established non-inferiority. That is, as of now, from getting approval for this particular drug in a market is okay, whereas long-term studies not available.
Sendil,
Sir.
good presentation.
Thank you, sir.
Imiglamin compared to metformin, you said insulin sensitivity is increased, beta cell function is increased, and it can be combined with any other drug. Especially DPP4, it is better.
Yes, sir.
Why the DPP4, the result is good, number 1. Number 2, you said compared to metformin, imiglamin is better because less lactic acidosis. Sanmuvel, please tell me how many lactic acidosis you have seen in your practice with metformin?
No, I have not. I have not come across any patient presenting with lactic acidosis with reference to metformin therapy, sir. No, sir. Muruganathan, sir, no, I have not come across.
Sir, your first question, sir. You asked one first question, was. Yeah, even though theoretically only we are studying like with metformin the risk of lactic acidosis, but preferably we will avoid in CHF or CKD, means with volume overload and all. But practically there is no risk, means we are not seeing any lactic acidosis with metformin. Sir, maybe because of the additional incretin effect, we don't know. Future studies will tell when it is compared with DP4 or other OADs. Future studies will tell, sir. So only one study has shown that with DP4 it has shown maximum efficacy. So a few more studies are needed. Whether that effect is consistent or that's like random effect, we don't know. Maybe this incretin effect, one is the additive incretin effect may be there. We don't know, sir. Because this DP4 inhibitors in animal model also, it has been shown that because of this GLP-1, it prevents the beta cell apoptosis. This also prevents beta cell apoptosis in murine models, not in human studies. Maybe because of that additive effect may be there, but future studies are needed, sir. Yes, sir. Yeah, yes, sir. Yeah, definitely it has to be taken into consideration, sir. Yes, sir. Yes, sir, definitely.
Thank you, Dr. Sendirajan, for an excellent talk and also good interaction. Now I hand over the mic to organizer.
I also thank Zaire for sponsoring this talk. For the last talk of today's session, sponsored by Nawaz, I request Dr. Chowdhury to deliver this talk on heart failure and reduce ejection fraction in form. So please come to the line. I also request Dr. Sendirajan to come to the line to stand this session.
At the outset, I am extremely thankful to Dr. Sedaraman, Chairman of Tamil Nadu RSSDA, who has, Tamil Nadu API, who has given me the opportunity to chair this session. Not only that, Dr. Sedaraman, along with his team, Dr. Sanmayvelu, Dr. Ashraf, and Dr. Anida and all other people, they have taken a great effort to conduct this conference, the first physical conference after COVID. So congratulations, sir. And we will see your success tomorrow, day after tomorrow, sir. And the speaker today for this topic is Dr. Sivakumar, cardiologist from Meenakshi Mission Hospital, Madurai. Sivakumar needs no introduction. He knows all people in and around Madurai and the Southern District. They will be knowing Dr. Sivakumar. He is such a known personality. He is a Vice President, Tamil Nadu International Council and past President MCS. And he has got other qualifications like fellowships and awards and achievements from Director Cath Lab, trainer PG cardio students. In fact, my brother's son was his intern for 1 year. He's a principal investigator and a co-investigator for more than 15 international and national clinical trials. In-depth knowledge of ICH, GCP and the local regulation to conduct clinical research. And his publications are author of a textbook, Common Cardiac Diagnosis Interventional Procedures for paramedics, and published in the year 2014. Wrote a chapter on IVS guided PCA in API textbook of medicine. Conferred a meritorious doctor award in the year 2013 from IMA. And teaches international cardiology community through live case demonstration, PCA webinars in various international topics. He actually conducted a cardiology conference two months back in the same hotel, wearing the same hotel in Madurai. We were all present for this. With this short introduction, he is going to give a talk on the topic called with reduced ejection fraction. His topic is with reduced ejection fraction. Heart failure with reduced ejection fraction. You don't all think he is going to again talk about the SGLT inhibitors. It is not. He is going to talk about the comorbid conditions like hypertension, diabetes, obesity, and all other comorbidities he will be dealing with. With this, I over to Dr. Sivakumar.
Thank you so much. It's great to be here and highly privileged among physicians. With respect to today's my chair for the topic, Dr. Selvaraj, and great physicians here. Special thanks to organizing team TAPICON Trichy, Dr. Sethraman and his co-physicians. I always envious about physicians because my mentor in cardiology used to refer physicians as pundits, and he used to call so-called super specialists, we call it subspecialists, because any disease needs to be a holistic approach, the broad spectrum. The moment we become a super specialist, we tend to have a tubular vision. Either it's a laziness or a non-committal, I don't know what to call it as. We will be focused more towards cardiology. We just hand over other problems to respective. But when you stay as a physician, you will have to take responsibility for each organ of the patient. In that way, have a great respect for physicians. And I call them pundits because a moment before we just saw when somebody was talking about time in range, immediately there was a physician here to represent time in range is not applicable to only antidiabetics, it is applicable to also VKS, vitamin K antagonists, antihypertensives. That's all about physicians. So with this preamble, basically I am here between the dinner and my topics, so I will try to finish as early as possible. And heart failure has to be approached as a holistic, not only from the organ as a heart, also it has an influence over other organs, so-called comorbids, because identifying the comorbids and treating them. But each heart failure, when they get admitted, there will be one trigger why he got admitted. Until otherwise you figure out those triggers, if you discharge them, he is high likely to come back again. If one heart failure patient get discharged from you and get admitted again, means somewhere there is a mistake in your previous admission in handling that patient. The precipitating factor, the triggering event, having identified the event, you have not optimally corrected it. That's why he has come back. So this is the idea about my whole topic, and let me take you on this. Give me a case. 66-year-old male, typical prototype of any patient getting admitted to CIC. If you look into take a rounds in CICU now, any intensive care unit, out of 10 patients, there will be 4 to 5 patients which will be heart failure. This is a typical patient admitted to the shortness of breath, orthopnea, extreme undue fatigue, and swelling in both legs. So it is easy to diagnose that this patient is come to you with heart failure. On top of heart failure, he is diabetic, hypertension, and dyslipidemic. That's what we call it as comorbidity. Of course, he has tachycardia, raised JVP, S3 gallop, and hepatomegaly, and his X-ray chest shows pulmonary congestion, and his ECG has low QRS complexes, and he has cardiomegaly and echocardiogram with reduced ejection fraction, and there is gross detection of global longitudinal peak strain. There is an elevated gross NT-proBNP. I have to put a small mention about why NT-proBNP, why not BNP alone. If you measure a BNP, for some reason, if the patient is on a drug called Arni, the drug will metabolize BNP and we will not make a diagnosis of heart failure. But this molecule NT-proBNP cannot be metabolized by any of the anti-failure drug. If some patient is on a group of anti-failure medications, if still NT-proBNP is high, that means his anti-failure medications are not optimized. You have made a diagnosis, you have treated the patient, but NT-proBNP has not brought to under control, means that still the heart failure is prolific. Whereas if you measure BNP, in spite of patient is on worsening heart failure, because of the influence of the drug, the BNP will come down, then you will think that you have managed the patient well. That's the idea behind why NT-proBNP. And of course, now the kit automatically measures only NT-proBNP along with the other molecules. It comes as a 3-in-1 test. And of course, this patient has normal renal and hepatic function. Somebody has smartly done a CT coronary angiogram, which has ruled out ischemic cardiomyopathy. His coronaries are normal, and he has hepatomegaly. So obviously, the diagnosis is heart failure, and he was started on Arni Vimada from Novartis, Sacubitril Valsartan, which is a combination of ARB and neprilysin inhibitor. And MRA could be either aldactone or spironolactone or eplerenone, and ivabradine, beta blocker, and nitric oxide donor may be nicorandil. Following 2 years of treatment, there was a dramatic improvement in symptom status, and 2D echo also showed improvement of EF, and he was continued on Vimada, and his symptom status came down from class 3 to stable corrected status class 1, NICA class 1, from class 3 to highly symptomatic to asymptomatic. With this preamble, let's move on. Why heart failure need to be diagnosed early? Because 80% of the time, the moment they get admitted, that's the only time you get to know their diagnosis itself. Already a known heart failure patient, like diabetic patient presenting as an MI, that's the first time you are diagnosing him as a diabetic. Like that, here is a patient, 80% of the time, it is misdiagnosed in the previous time, and during its ICU admission only, first time the heart failure is diagnosed. In its first admission itself, when the diagnosis of heart failure is established, his 5-year survival is only 50%. Such a worsening disease, worse than urogenital cancers like CA prostate, worse than CA cervix, worse than CA breast. People think non-infective, non-communicable disease like heart failure is taken granted. One can move on with the heart failure. It is not the story. If you see 5 heart failure patients today, after 5 years, you will see none of them. That's such a worsening mortality heart failure. But somehow that has not created that alarm among the physicians like cancer. And Novartis, we should thank Novartis specifically because this is the era where the trend in heart failure is to stick on to guidelines, to go with guidelines. The trend currently with any youngsters, postgraduates, beginners is to take a help of app, not only in healthcare, even in automobiles, anything. Get into the app, get your problems, scores, all that. They have nicely introduced an app called Optima, where you can go into a specific scoring system called the Netherlands Prediction Rule. You have to just type Optima, O-P-T-I-M-A. It will take you to this page. That page will tell us where to go. If you go to the Netherlands Prediction Rule, it will tell, are you in a heart failure of milder form, intermediate form, or high risk form? If you select in the Optima app, if you select a Framingham heart failure criteria, it will tell you whether your patient is positive for heart failure or negative for heart failure. Similarly, if you use this app, the previous scores which I told about Netherlands and Framingham is for an outpatient assessment of your heart failure patient, whereas other 2 scores like ST-SCD score and Barcelona score is to assess the risk, what will be the outcome of that patient in this admission. And there is another 2 scores, India discharge score. There is a patient getting admitted with a decompensation in ICU. He got stabilized with IV diuretics and inotropes. Decompensation has been compensated now. His triggering factor all diagnosed. Now, pre-discharge, what are all the drugs has to be put on this patient? For this also, this app is going to help you. This app will have a series of drugs starting from AC inhibitor to ARB to ARNI to MRA to beta blocker to ivabradine to digoxin to hydrolysine nitrate, CRT, ICD device therapy. You have to just go into the app. The app will suggest you this particular patient which to choose. Whether to choose Arni, whether to choose Ivabradine, whether to choose CRT device. This app will simply help you. I think I recommend, if not senior physicians, at least postgraduates, to take help of this Optima app to diagnose, to categorize, to risk assess, and to decide your pre-discharge advice for the patient. Go home safely, not to get admitted again and again. Because with each hospitalization in heart failure, the mortality goes up. So let me come on to the topic of interest today, the comorbidities. Why we need to be worried about comorbidities? Because comorbidity itself, already I am telling a disease where the mortality is 50% in 5 years. If there is an add-on comorbidity, further prognosis is poor, and the therapy for heart failure itself may worsen the comorbid condition, or comorbid itself will have an influence on heart failure itself. That's why we need to be very serious about it. We all know that what is the benefit of treating hypertension? There are two important diseases taken care by treating hypertension. One is heart failure, another is stroke. That's what the Jupiter trial. Healthy volunteers, when they were put on statin, the reduction in stroke was 60%. A simple drug, statin, in a healthy volunteers was able to reduce stroke by 60%. So similarly, if hypertension is taken care, there is 60% reduction of stroke, 50% reduction of heart failure. Somehow, physicians, patients are all worried about diabetes. Of course, we need to worry about diabetes because diabetes is a killer disease. But when you focus heart failure as alone an entity, which not only questions your life, it is going to question your quality of life. You are going to live with a disease with a bad quality of life. We need to have simple exercise like just control someone's hypertension. Your tendency for developing heart failure, your tendency for controlling heart failure is such a huge. This is a particular trial where in 2000, a period from 2013 to 2016, when they analyzed, there is an increased trend towards hypertension, CKD, ischemic heart disease, which is influencing on heart failure admissions. Similarly, when they analyzed acute decompensated heart failure in ICUs, again, it is uncontrolled hypertension. Recently, I encountered one very important VIP patient who came to me post-bypass, 20 years, low EF, recurrent heart failure, tachycardia, wide QRS, tried to manage him on anti-failure drugs. Finally, even I had to put him on cardiac resynchronization therapy. It's a device to control heart failure. It is like a pacemaker where the leads will be put on 3 different chambers. It will resynchronize the heart to contract in a way the heart failure will improve. In spite of that, the patient is getting admitted again and again. Do you know what was the reason? It is an uncontrolled hypertension. Every time he gets admitted with isolated systolic hypertension. The moment you put him on isoleucine, the combination of nitrate and hydroleucine available as 20 and 37.5 thrice daily, dramatic improvement. Nothing worked, even a device didn't work. Continuous monitoring, ambulatory blood pressure monitoring of home BP monitoring of his blood pressure and proper antihypertensive has solved. Even I was questioning myself whether I could have postponed his device therapy some more later point of time. So the simple exercise of which is precipitating in this particular individual, it could be dyslipidemia in that patient. In a patient B, it could be hypertension. In a patient C, it could be something else. Identify that and treat. And if you look at comorbids, previously I thought it is in the preserved ejection fraction where the comorbids are high. It is not the case. It is in a heart failure with reduced ejection fraction where the comorbids are 50% of the time. Every other heart failure patient will have a comorbid. Moment a heart failure patient is having one or more comorbids, his long-term survival is highly questioned. So, what is the influence of diabetes and heart failure? We know that heart failure as such will cause water and sodium retention. When there is water and sodium retention, there is ROS and sympathetic nervous system activation. When there is SNS activation, there is tendency for diabetes, and diabetes as such will lead to obesity, insulin resistant. When full-blown diabetes sets in these kind of a people, then you have a macrovascular damage, MI, post-MI, low EF, heart failure, ejection fraction, or diabetes is not causing MI, but it is causing endothelial stiffness, diastolic resistance, then it causes heart failure with the preserved ejection fraction. Heart failure preserved ejection fraction is almost 30 to 50%. No cardiomegaly, flash pulmonary edema, ECG normal, EF is super EF 70%. One shot of Lasix, patient goes home well next day. This is nothing but your heart failure of preserved ejection fraction. Definitely there will be some triggering factor in that patient. Usually it will be hypertension, diabetes or dyslipidemia. If you address those comorbids, there is a dramatic long-term survival, better quality of life, and a better long-term survival too. In patients with the diabetes, there is 1.6 times increased risk of death as well as heart failure hospitalization. When you look at hypertension as a comorbid in heart failure, hypertension causes more heart failure in women than in men, and hypertension increases the risk of heart failure by 40%. When you analyze two groups of patients, mild hypertension versus moderate to severe hypertension, poor the control, greater the tendency for hypertension, and isolated systolic hypertension as well as systolic diastolic hypertension both can lead on to heart failure by 80% of the time. And look at this, I said heart failure alone as an entity without comorbidity, the 5-year survival is 50%. The moment comorbid like hypertension is on top of it, the 5-year survival now becomes only 25%. So a heart failure patient becomes an hypertensive too, then his 5-year survival is just 30%. Such a worrying figure. And not only that, quality of life, isolated heart failure patient against heart failure patient with the comorbids, the quality of life is 10 times poorer. And what is the association between dyslipidemia and heart failure? We all know that among the precipitating factors for heart failure, one of the commonest is chronic coronary artery disease, chronic ischemic heart disease. Naturally, if a statin is put on, there is reduction of MI. So naturally, the tendency for heart failure should come down. So all heart failure patients, irrespective of whether they have a associated coronary artery disease or not, still I will worth consider a statin, because statin can either prevent an ischemic heart disease, or if it is already known ischemic heart disease, it can further prevent recurrent infarcts and heart failure. And if you put some heart failure patient on statin, there is, if not put on statin, if there is a low HDL and high LDL, their risk of heart failure is ranging from 30 to 40%. And why we need to manage heart failure? As I said earlier, the comorbid disease itself will worsen the outcome, and your therapy for heart failure like beta blocker will worsen asthma. Your therapy for asthma like beta agonist will cause tachycardia and tachy-induced further worsening of EF. And when there is associated acute kidney injury, now you will not be able to put ACE, ARB or ARNI. So we need to know your guideline-directed medical therapy and its effects and side effects. We also need to know the exact comorbid condition and what way it is going to influence. Then only because the polypharmacy is a way to care diabetes, hypertension, asthma, MI, heart failure. Whenever a disease demands a polypharmacy approach, we need to know the drug interaction within the among the drugs. Otherwise, your therapy. Do you know what is the current reason for recurrent hospitalization apart from whatever I spoke? The current reason for recurrent hospitalization is influence of your drug. For example, you are fantastically treating a patient, but a patient is getting admitted to you in ICU. Do you know why? It is because of aldactone-induced hyperkalemia. It is because of AC inhibitor-induced cough. It is because of beta blocker-induced side effects. So we need to know in each hospitalization, but I'll be happy about the hospitalization due to drug rather than hospitalization due to worsening heart failure. Because hospitalization due to worsening heart failure will kill the patient. Whereas hospitalization because of your drug side effects will cause only a loss of money from his purse, but it will not question a life. But still consider we need to know the side effect profile because we can prevent those admissions. Even though it is not endangering to life, it is going to cause a loss of money, so we need to know. The ideal example is, a patient is admitted with decompensation, started him on IV diuretics, high dose. By the time of discharge, if you don't reduce the dose, he is going to get admitted with prerenal azotemia. So, diuretic in heart failure is only for symptom relief. Patient is diagnosed with volume overload, IV diuretic given, volume overload is taken care. Admission weight is 80 kg. On the day of discharge, 70 kg. That means that 10 kg is taken care by diuretics. But with 70 kg also, if you discharge him with high diuretics oral, then he has to get admitted with AKI. So, moment volume overload is taken care, you have to remove the loop diuretic from your, because the guideline recommendation is only 4 drugs: ARNI, beta blocker, MRA, SGLT2. That's the bottom line. So this is what we need to know about comorbidities and its influence. This is fantastic. American College of Cardiology 2022. This is the first time in the history of medicine. Generally, physician's statement, Pandit's statement is, when somebody is doing well on some drug, let's not tilt the balance. Against that was atenolol. People doing good on atenolol. Will you change or not? How many say, I will stay, I will change? But the new onset of incidence on atenolol was 35%. Patient is doing very well, but the new onset of diabetes was 35%. That made people to change from beta blocker to. So, this is the first time in heart failure, in spite of a patient doing well on AC inhibitor or ARB, because of tremendous reduction in mortality, the guideline has recommended, even though doing well, change it from AC inhibitor to ARNI, that is a combination of ARB and neprilysin inhibitor. I'll just little bit tell about this drug. ARNI is combination of angiotensin receptor blocker and neprilysin inhibitor, ARNI. It is a combination of valsartan, 50 mg and 50 mg of sacubitril. Neprilysin inhibitor is an enzyme naturally degrades natriuretic peptides. When natriuretic peptides are degraded, natriuretic peptides are very useful molecule in a patient with heart failure because it causes water and salt loss. And the ARB, we know that it acts through the renin-angiotensin-aldosterone system. When you combine this renin-angiotensin-aldosterone system, that is valsartan, and this neprilysin inhibitor sacubitril, we are removing a bad molecule called ROS, and we are promoting a good molecule called natriuretic peptide. So together synergistic, they do well. If you put somebody isolated on ramipril or telmisartan against this combination, it does wonders. That's why the guideline recommends if somebody is doing well on ARB or ACE, still worth changing them because that so-called molecule called sacubitril, which is a promoting endogenous natriuretic peptide to stay on and causes water loss and sodium loss. Again, this molecule is being endorsed by European Society of Cardiology in 2021 in both de novo patients as well as some patients on already guideline directed medical therapy like beta blocker, MRA and SGLT2. You can go on, change from AC inhibitor to ARNI. So what is the evidence? Apart from backing by the guidelines, what is the evidence? Yes, this is by the paradigm trial where there is 20% reduction of CV on top of. In spite of so many heart failure drugs available, why there is a 5-year mortality still 50%? That means We need to identify a magic pill. I can definitely say this is a magic pill. On top of beta blocker, on top of aldactone, on top of SGLT2 inhibitor, it has reduced extra another 20% reduction in death and heart failure hospitalization. And similarly, when this drug is put on diabetic patients, there is 29% reduction in necessity for insulin. And compared to ramipril, only 23% were put on OHA. Like as I said at Jinalal, when AC inhibitor or ARB against ARNI, the need for insulin was comparatively lower in ARNI arm than AC inhibitor arm. The need for OHA also lesser. So this drug not only takes care of the heart failure, it has a pleiotropic benefits. It influences a whole lot. Like SGLT2, the diabetologists say, it's a molecule of anti-failure molecule. We don't know how the drug works. It works in multiple pathways to take care of heart failure, apart from diabetes control. Similarly, this ARNI also, apart from proposed mechanism of RAS and neprilysin inhibition, it has some other pleiotropic pathways to make sure his BP is taken care, his cholesterol is taken care, diabetes is taken care, the need for anti-diabetic is taken care. Probably that's the reason. Why Surya Kumar Yadav is very famous today in T20? Because he is not as like any other player. He plays shots all around the ground. That's why he is a number one T20 player. Similarly, a drug has to work all around. Otherwise, you'll be a conventional player and you'll go out of the team. Now, the Indian cricket team cannot survive without Surya Kumar Yadav. That is because of his pleiotropic, multiple shots, varieties he has. He can play behind the skipper, above the bowler, like that. You need a drug to work multiple pathways. Sacubitril valsartan, when it is put on patients with elevated BP also, it has a 20% reduction in death and heart failure hospitalization. And this sacubitril valsartan, recurrent hospitalization. I was talking about with each admission, the mortality worsens. It can reduce readmission by 60%. And this is another interesting slide. Irrespective of the statin, some heart failure patient, for some reason, you are not able to prescribe statin. For example, a heart failure patient is having severe myalgia. You are doing a CPK total is raised. You are doing an LFT is altered. You are not able to put a statin. And patient was just left on beta blocker, aldactone, diuretic, and sacubitril. Sacubitril itself, sacubitril valsartan itself, so-called Vimera from Novartis itself, is like working like an anti-cholesterol drug, like a statin, reduces cholesterol and triglyceride, irrespective of the statin, on top of statin. So, the learning from the case which I quoted in that 60-year-old male who got admitted to the heart failure, diabetes, hypertension, dyslipidemia was, just go with the guidelines. Take the help of Optima app, diagnose your case, get to know your risk categorization, get to know your survival of that patient, get to know his comorbid conditions and treat them. You are going to have tremendous reduction in CV death, heart failure hospitalization, and all-cause mortality. This is not just by this slide set, it is by the ACC 2022 and ESC 2021. With this, I conclude my talk. Thanks one and all for a patient listen.
Thank you very much, Dr. Sivakumar, for your extensive lecture on the heart failure with a reduced ejection fraction and a comorbid condition, especially on hypertension and diabetes and dyslipidemia. The lecture is now open for discussion.
It's a very excellent talk, sir. Very much enlightened. And
Can I finish his question?
He's asking.
Yeah, stage 5 CKD. Yeah. Yeah, that's what. See, that's what my very first slide was. Early diagnosis is the key. Whether it is SGLT2, whether it's EMPA, DAPA, whether if it's a NOVAC, your heart failure patient on stroke, NOVAC, or this drug. Extreme CKD, because it is in a sartan, I said it's a valsartan. It is tough to consider this drug, but still I will consider, provided you are very sure that it is only CKD, there is no AKA component on that. In spite of eGFR less than 30 ml, I will still consider this drug, and this is not dialysable. This is going to do wonders, but the caution is you have to very frequently check his creatinine and you have to check his potassium, because it is again ARB, it is going to cause hyperkalemia and you are going to lose the pitch. And he is on beta blocker also. So a patient on ARNI in a stage 5 CKD along with the beta blocker, then hyperkalemia will kill the patient, isn't it? That's the only caution. You need to make sure it is not AKA, his urine output is good, and he is on follow-up, every 4 weeks follow-up, his creatinine is not shooting up. Initially there will be a shoot up, but it will not continuously on a rising trend, and more important is potassium is eukalemic.
Sir, you have, the heart and lungs are the husband and wife of the mediastinum. If one goes wrong, it will be reflected by other.
But lung is a pair and heart is a single.
Oh, okay, sir. That is, you can consider whether heart or lung is husband or wife. But in one of your slides, one end of the spectrum, the prevalence of heart failure, you mentioned about smoking, and the other end of that COPD. I want you, as a cardiologist, your experience with COPD and heart failure.
Yeah,
because it is a lot of things we have to give the beta agonist and how to control the heart rate at the same time COPD, whether you are meeting with most of the right heart failure or the left heart failure, or how to diagnose early, because COPD is also a very slowly progressive disease, and also it is also like heart failure, we have to combine both to treat.
I think this is absolutely need of the hour. Particularly we are living in an era, முன்னாடிலாம் வந்து கிபி கிமுன்னு சொல்லுவாங்க. இப்போ வந்து ப்ரீ கோவிட் போஸ்ட் கோவிட்னு தான் நம்மளோட ஹிஸ்டரியை பிரிக்கணும். போஸ்ட் கோவிட், ப்ரீ கோவிட் இட் வாஸ் ஸ்மோக்கிங், போஸ்ட் கோவிட் need not be a smoker, but it is a post covid lung means it's a bad lung. So the bad lung is definitely an important comorbid in a heart failure. Why? Because COPD is a usual comorbid in a heart failure with a preserved ejection fraction. And the moment the patient is COPD, when you put them on beta agonist, steroid is good, but if you put them on salmeterol, then it is going to cause tachycardia. Then tachycardia is going to cause increased oxygen demand, more workload, and the heart is going to, so tachycardia induced myopathy. So that is one problem. Another end is, any heart failure patient has to be put on beta blocker, because beta blocker is going to reduce sudden cardiac death, but beta blocker will worsen asthma. But what is the outway for this? We need to know among the beta blocker which is a lung friendly beta blocker. It is nebivolol and carvedilol, but still they can also cause wheezing. So we need to start them on a low dose, slowly titrate. If patient is not tolerating beta blocker, he is tolerating at a lowest dose. For example, he is tolerating carvedilol 3.125, but if you increase it to 6.25, 12.5, he complains. My father complained. Now what is the way out? Fantastic way out. Bring carvedilol at the lowest possible dose, combine ivabrade. Now there is a company which is available, combination is available. Cardi was a year. So this is what it is. This is an individual approach. Each physician can react differently because his patient is a different patient. Then pneumovac vaccine. Also, see, my surgeon was Dr. Raghuram. I think he has a famous history related to this town. He's worked in Trichy GH as a general surgeon. Now he is in all his bypass patients, post-bypass, every year he put them on pneumovac. So this is what my mind comes to. Vaccine, post-COVID era, bad lungs, beta agonists avoid, beta blockers, choose a very good beta blocker, lung-friendly beta blocker. If he is not tolerating, operate at the lowest dose and bring in ivabradine along with it. Why we don't consider ivabradine as a principal molecule? Because ivabradine can only improve the quality of life. Doesn't have a say on mortality. Beta blocker is a king. Beta blocker always a king. Whether it is CAD or heart failure, it's a king because there are only two anti-failure drugs which can reduce sudden cardiac death. One is beta blocker, which is the another one. Any postgraduates? Apart from beta blocker, which is a one anti-failure drug, which has a say on MRA, because it is an anti-fibrotic agent. That's the same reason SGLT inhibitors also become popular. And why MPA kidney trial, DAPA kidney trial become famous? Because SGLT2 inhibitors also as an anti-fibrotic agent. That's why they were able to prevent the progression of CKD.
Sir, what is the lowest level of systolic blood pressure you start ARNI? And what is the lowest level of systolic blood pressure you uptitrate ARNI?
Yeah, the uptitration of ARNI is every 2 to 4 weeks. I can reach my blood pressure as low as 100. See, we cardiologists worried more than systolic blood pressure, central aortic pressure and mean arterial pressure. If someone's blood pressure is remaining somewhere around 100, but if he is MAP, mean arterial pressure. What is mean arterial pressure? Can anybody postgraduate? What is MAP, mean arterial pressure? Diastolic pressure plus 1/3 of the pulse pressure. That's mean arterial pressure. Very easy to calculate. If the mean arterial pressure is maintaining 50 and 60 and above with a systolic BP of 100, you need not worry about it. His urine output is going to remain as 20 ml per hour, provided if his mean arterial pressure is 60, irrespective of his systolic pressure, which remains around somewhere around 100 to 110. So, I will aggressively uptitrate the same patient which I quoted, that VIP patient. Every time I send him with ARNI, beta blocker, isolazine, he goes to his physician and he stops. He tells his BP is 110, I stopped all. He comes with heart failure. Typical prototype, same patient. Gets admitted with surge of isolated systolic hypertension, antihypertensives, getting controlled, going back into his original town, somebody knee-jerk reaction. Somebody can tolerate. My mother's BP is all the time 90. Of course, her weight is only 50 kg. 90 blood pressure. You need to see the pulse volume, tachycardia. If somebody's blood pressure is 100, but there is no compensated tachycardia, that means what? His blood pressure is tolerating. So we need to know somebody's BP is 110, he is not tolerating. That is hypertension. See, that's what in medicine I always used to tell. Hypertension is an entity. Hypotension is not a permanent entity. Hypotension is just an event. It could be an event because of drug, it could be an event because of diarrhea, it could be an event because of poor hydration. It is just a one-time event. It is not a permanent entity.
Sir, in response to his question, that is the lowest systolic BP, we need to modify our other drug therapy like nitrite, digoxin, we can also, and the diuretics.
Yeah, absolutely, that's what. See, this is what it is. When they get admitted to the decompensation, IV diuretics, all that. Moment he get discharged, there is no loop diuretic. There is no nitrate. So two important drugs are now out. The same patient, he was on nitric oxide donor. By the time he discharged, I will not put the patient on nitrate because nitrate doesn't have a mortality benefit. So simple exercise like optimal dose of beta blocker, bringing in ivabradine, which doesn't have an influence on hemodynamics, shutting the loop diuretic. And when you bring in SGLT2 inhibitor now, on top of, I heard somebody talked on SGLT2 also in heart failure. Now SGLT2, MRA, ARNI, all going to cause water loss. So you need to operate at the lowest possible dose of ARNI, lowest possible dose of your MRA, lowest possible dose of your SGLT2. I think that was a fantastic insight from sir. Which trivial? Yes, 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 absolutely, always, always. That's why all heart failure patients, I don't look for a cause of anemia. I just give them a pharyngect injection. 1000 mg, it can be given in outpatient, 1000 mg slow IV. Dramatic improvement.
That is based on the ferritin level as well as TSAT.
Yes, yes, yes.
Many time in our practice, we come across on routine screening.
We come across?
Routine screening of by echo in diabetic patients, they do diastolic
That's
dysfunction.
okay.
And otherwise also, many times we come across heart failure like reduced HL or any signs. Patient may be got admitted for any other for disease. So how early you can recognize or any marker or seen by echo or in any anti-propion or something like that. You can do in diabetic patients and evaluate early.
Yeah, excellent question. I will take your question into two parts. I will just brief what his question is. Question A is asymptomatic LV dysfunction, how to approach. If you look at a heart failure, it has 4 stages. Stage A is at risk for heart failure. Any diabetic with hypertension is at risk, but it's not a heart failure, but at risk. Stage B is already a risk factor has set in. He has branded as diabetic. He is branded as hypertension. He is branded as CAD MI. He has developed an MI. So asymptomatic post-MI LV dysfunction. Stage C is post-MI symptomatic LV. Classical example is post-MI LV dysfunction symptomatic. Class 4 is stage C is of course symptomatic at rest. So to properly treat asymptomatic LV dysfunction, we need to know what has caused his LV dysfunction. Is it a CAD? 70% of the time it is CAD. Only 30% of the time it is non-CAD. In non-CAD it will be diabetes, dyslipidemia or hypertension like that. So asymptomatic LV dysfunction, when it comes to you, the first thing I will do is a proper echo assessment, CT coronary angiogram to rule out associated coronary heart disease. If the associated coronary heart is negative, echo is showing dilated LV or non-dilated, reduced EF, then put them on LV remodeling drugs. In spite of asymptomatic, put them on LV beta blocker, ARNI, MRA. They should do well. If diabetic, obviously SGLT2. So asymptomatic LV dysfunction also, that is stage B of heart failure. If you aggressively put them on LV remodeling drugs, that is why heart failure is now 4. Heart failure, reduced ejection fraction, heart failure with the preserved, heart failure with mid-range EF, heart failure with the recovered EF. That means what? A postpartum cardiomyopathy recovered. I have seen patients, recovered patients stopping ACE inhibitor now, they have gone back to low EF. So it is an exercise like anti-epileptics. We never know until you stop it. After 3 years, the protocol is after, I'm not a neurologist here, after 3-5 years, if you stop it, if it doesn't develop for a period of another stretch of 2 years, then you permanently stop. If you recognize, so the tough exercise, tough call. Depending on the etiology, you can react better. And of course, your second question is routine diastolic dysfunction. Of course, it is always, that's why I said in one of my slides, global longitudinal strain. It is not just about diastolic dysfunction. Somebody picks up, I think this is Trichy, Manivasam is known for that. This is the one who made this strain popular. If the global longitudinal strain is grossly reduced, then it is definitely a diastolic dysfunction which needs to be addressed. It could be most of the time uncontrolled hypertension, undiagnosed CAD, very stiff coronary, stiff arteries, your typical atherosclerosis overall, endothelial dysfunction, statin will work. So we need to know in that particular diastolic dysfunction, what could be the nearest possible etiology and treat that. In a patient A, if it is atherosclerosis, statin will work. In a patient B, if it is hypertension, antihypertensive will work. Yeah.
Thank you very much, sir. Already Paul.
It's already 9:30.
Healers are restless for the food. So thank you very much, and we will close the session.
ஆமா ஆமா லாஸ்ட்